What's up, gang? How are we doing? I am alive. Everything is great. I am breathing oxygen and I'm on my own 2 feet. Which is probably better than I can say about maybe half of my patients today. But that's okay. I'm picking up some extra shifts at work this month, so I might not have as much time to be streaming. But I do want to, just like, I don't know, just like chill, right? Just like hang out with you guys. Is that so much to ask? I was going through my YouTube live streams and I was just like, dang, like I've just been collabing this whole time, right? Like I haven't had a chance where I can just like sit down and like hang out with you guys and like read chat and stuff. So that's kind of just what I wanted to do. Senor Saiken is back. Yo, that YouTube comment was so funny. It's just like no one's ever called me Senor Saiken before. that one made me laugh. Your stream title got me cracking up. I don't know why. It's just SoloQ. Because I'm not duo queuing with JF anymore. It's SoloQ for me. But yes, hello everybody. How are you doing? We don't have to get started with questions right away, right? Because I'm not hanging out with anyone today. But I just wanted to chill, Like it's almost been a month since I last did like my own solo stream, and I just got to just hang out and read chat. Because usually what I was doing is like I was reading chat while like the other person on my stream was talking, or I was like fielding questions for them, and it's just like, dang, I haven't been able to just spend time with you guys. 4th year med school finals are on Thursday. Fourth year? What the fuck? You still have finals in your 4th year? What do you mean? Internship starts in 2 days. Why are you still studying for finals? That's crazy. From doctor to senior. Actually, somebody pointed that out. In the UK, they said it was doctors, but I think it's surgeons actually. In the UK, you start as a doctor, after you graduate med school. But I think in surgery, when you go into surgery, you lose your doctor title and you go back to like Mr. or Mrs. Because like surgery evolved from like barber school. So it's like a really weird, it's a really weird way of like how they do it. But it's like technically like the honor of becoming a surgeon means that you lose your doctor title and you go back to being a Mr. Mrs. Like what the fuck? That's so stupid. I found so many medicine related VTubers because of you, like the gates opened. Aw. Yeah, I mean, I have not. Okay, I've been streaming the longest out of all of us because I started streaming when I was in med school. So 100% I've been the longest streamer doing this, but there are a couple of VTubers who did this before me. So Shiori and Ruki. Shiori is in the Philippines and Ruki is in Indonesia. I know for a fact, like when I started VTubing in 2022, they were already around. So they've been doing it as a VTuber for a while. But for me, from med school to residency to attending hood, I've been a streamer the whole time. I just used the face cam for like the first 5 years of it. And then I became a VTuber my 4th year of med school. But yeah. Old school bloodletting at the barber, bringing it back. C mentioned. Yeah, I have a lot of fans like from Southeast Asia. Like if you look at my YouTube demographics or even like my Twitter demographics, I think, and you break it down, it's like obviously US is like 50%, like Canada is like 10%, and then it's just like Philippines, Indonesia, Thailand is like 9% each. I'm like, what the heck? Like where did you all come from? What was I saying earlier? Oh yeah, so I am going to Offkai at the end of this month. So I wanted to pick up some extra shifts at work so I could stack out my vacation time. And I'm moonlighting for like 7 extra shifts too. So I do have time for vacation at the end of the month so I can go to the con, but also I wanted to grab some extra money because this is America and everything is fueled by money. So I want to try to stream maybe on the weekend next, maybe like 5th of July, something like that. I want to do something stupid. Like I want to play like the House MD visual novel, like something just like absolutely unhinged. Hi Zom, thanks for the raid. It's not the case in India. Even surgeons are called doctors. No, yeah, everywhere else surgeons are called doctors, but I think just in the UK system and like historically how the British system has done it is that just like doctors were doctors and surgeons weren't doctors. So when a doctor graduates med school, they become a doctor, but then when they become a surgeon, they revert back to sir or whatever. Like, it's so dumb. He is a hospitalist, aka generalist in the hospital. Yeah, so I did internal medicine residency. I did internal medicine residency. I graduated in 2025, and I just finished my first year of being an attending. I'm also in an admin fellowship, so I do dabble in a bit of like administrative duties. A lot of my stuff is in database work and the EMR. And part of my program is that they also pay for my MBA, so that's a pretty sweet deal there. Yeah, there is a House MD visual novel. I guess it's not really like a visual novel. Maybe it's more like a puzzle game. But there exists one for the DS, and I've been meaning to play it just because it was very stupid. But you know, I just want to do something stupid, guys. Like my past like 3 streams have been like Doctor Duel and board review. Like I don't think on YouTube streams, at least, like I don't think I've like done a single like game stream. Like the last time I streamed a game was my Donathon for my birthday, and that was just because I was playing Trauma Team the whole time. I wish I could stay. It would definitely help me for my PA boards next month, but I have an early shift for inpatient psych. Aw. Looking forward to the blog. Yeah, this the good thing about streaming on YouTube is that everything just goes up automatically anyway, and then my editors work on each stream VOD and toss everything up. Oh, this is a good question. Is a hospital admin fellowship similar to a clinical informatics fellowship for IM? Yes and no, but for me personally, actually, I did apply for clinical informatics too. Clinical informatics is actually something that I was really curious in because just doing a lot of schoolwork, and you know, with my very basic coding background, I think clinical informatics is really just like the future, like the intersection of hospital medicine and data science. And you need doctors who are fluent in both languages to be able to understand what these gobs and gobs of data are doing on the back end, and not just letting it sit there and trying to treat patients, right? Like healthcare is in a crisis in this country, and I think a lot of things, you know, have the ability to change with technology. It's just that we're not leveraging it, right? Like medicine seems so foreign to tech bros, and tech feels so foreign to medicine bros that people don't communicate. And I think clinical informatics is one of those fields, like in the past 10 years, where you're really going to be leveraging a lot of traditional like business intelligence stuff in the medical field. And that's really going to transform how we deliver healthcare in the next couple of years. Would love to hear a seminar on this someday. My whole thing is really administration, clinical informatics. So my MBA, my concentration, I'm doing like a healthcare management concentration, but I do get to do clinical informatics rotations with the CI team at our hospital. So even though I'm like an administration fellow and I'm not formally doing a clinical informatics fellowship, our hospital actually doesn't have its own clinical informatics fellowship. So the CI people that we have are like 100% on board with like teaching me like everything that they know. And that's really cool. Medicine and programming, at least to me, have so much heavy jargon. Yeah, I mean, it's hard because it takes a lot of dedication from both ends in order to really understand both, right? Like, of the subsection of doctors that get their MBA to like understand the business of medicine, like imagine maybe like 10% of those are like the doctors and the database, the doctor who's fluent enough in database science or like QI or qualitative studies and actually understands how to leverage like database work in medicine. Like much less popular path than like the MD MBA. But I think data science is really where the future of medicine is going at this point. So that's something that I'm trying to incorporate into my admin fellowship. Why would you get an MBA? Because I want to be in leadership. Like, yeah, I don't mind being a hospitalist. I enjoy being a hospitalist, right? Like it's a pretty cushy gig. I made a video on this in like the one where I explain internal medicine. I mean, being a hospitalist is great. Like it's a good schedule. I like doing 7 on, 7 off, but I'm like 30 or 31, right? Like if you're like 50 years old, if you're 55 years old, like are you still gonna be a hospitalist the whole time? Like are you gonna run up and down the hospital like responding to codes and shit? Like I think for my skill set, I mean, I was chief resident at my program, so I kind of self-selected into administration, to be honest, because it's just like I enjoy taking care of other doctors to help them take care of patients better. And my specialty in administration is managing a team in order to let me do that. Right. So, I mean, I'm tired of non-physicians getting their grubby little mitts on healthcare, right? Like there are so many doctors, there's so many, private equity, like all these things, like BlackRock buying out hospitals, or like Amazon making One Health a thing, right? Like there's so many times where you hear like businessmen ruining medicine and taking kind of like that art and the soul away from it. So why not do both, right? Like I'm still pretty young, like doctors wise, like I went straight through school. I'm still, I'm chilling, right? And I want to add more to my resume that helps me do better in the system. I don't have anything against people who decide to be hospitalists for the rest of their life. It's just that I think I want to do more. And that's why I enrolled in an admin fellowship. That's why I wanted to do one that specifically got me into business school. And, I want to be like part of hospital leadership one day, where I'm actually in the system in a position where I'm able to make change, in the boardroom, actually taking care of millions of patients at a time instead of just, the 18 to 22 on my list or whatever. You should get an MPhD just for funsies. No, thanks. How does a business-minded leader not seem like a penny pincher and a metrics chaser to the people they manage? Yeah, I mean that's why you need the MD and the MBA, right? Like I think a lot of what happens in primary care, I mean, you see like these private equity firms buy out clinics and they're just like, hey, like you have 15 minutes, you need to see X amount of patients a day, you need to bill for XYZ amount of codes in your patient charts and blah, blah, blah. And it's all about metrics, right? But I want to be somebody who understands like, yes, these companies are looking to make a profit here, but I am still a doctor by training. And I am here to, defend a policy that makes sense, not one that's going to generate money. Because at the end of the day, I don't think you can have both. Because as you see in the current landscape of things, like 15 minutes is not enough to take care of all of your patients' concerns in one visit, right? So personally, for me, it's hospital medicine because I'm internal medicine. That's what I'm trained in. But I think going forward, like in the future, like I want to help a hospital take care of its patients better. And I think it's just a lot more feasible to do that from an administration side than it is from an individual doctor side. That goes to the nature of business. Some businesses are more technical and require more technical aspects. Others are marginal revenue equals marginal cost. Rational businesses stink at the margin. Also, I just assumed MR is marginal revenue equals marginal cost. I took econ 2 semesters ago. I don't... What am I thinking about? Didn't business people basically prevent physicians from becoming president, CEO of hospitals? Business people, yeah. So technically that was Obama in America. That was one of the big things of the Affordable Care Act, where because they designed the system so that they didn't want doctors able to be in a position where they could kind of cater or be picky with their insurance providers, right? Saying like, I'm only going to take private insurances. I'm only going to treat patients in the hospital that can pay me well. They basically repealed this for like most healthcare organizations. If you're like Kaiser or some other like older systems, you may have gone grandfathered in. But yeah, that was basically like from an anti-kickback angle, something that happened in 2008. So yeah. Make sure to publicly tell people you're mentally stable and don't plan on disappearing when you start challenging private equity. Yeah, right? Like it'll be like body found in river, young upstart Dr. VTuber found floating. Oh well. Sounds like you want to do what my father did. He was a flight nurse, switched to health admin, and climbed the ladder to multi-hospital leadership. Yeah, I mean, that's what I want to do. We don't have enough people with a business nous on our side. Oh, isn't nous like a British word? Yeah. We don't have enough people with a business nous on our side. That's why I want to do both, right? I think a lot of doctors just get to the end and they're like, awesome, I'm going to practice, I'm going to make a ton of money, right? I'm going to start a family, I'm going to do all these things, I'm going to start investing, I'm going to buy a boat, I'm going to learn how to fly. But, I'm still relatively young, right? I still have the energy to do these things, and it's something that I am personally passionate about in healthcare. And it's like, why would I help 20 patients a day on my list when I can take care of 20 doctors in the hospital under my service, under my purview, taking care of 400 patients a day at that point, right? And I think the net good that I can do with the skill set that I have and my personal interests where they align, like that's something that I want to see myself in. And like, yeah, I have to wear a suit every day. Like I have to go to meetings. I can't just like do medicine full time. But I think, in a couple of years, I'll be a lot happier with the kind of doctor that I am. I love econ until they pretend they're scientists. It's just like it's like the difference between econ and accounting. I wish. I wish. I never really even thought about administration as a specialty, really. The viewpoint of being able to help doctors to take care of patients is actually really interesting. I think a lot of people, this is probably something that probably popped up maybe in the past 20 years. But like I think a lot of doctors would do a lot better had they more of a business sense, right? I mean, I think I made a tweet about this a while ago, but it's the reason I do this is because I want to be somebody who can fight back against the tech culture that just rampantly cannibalizes a lot of the human elements of healthcare, right? Just like, how do you responsibly use AI in medicine? Like, AI is coming to this field, whether you like it or not. It's already integrated in our EMR. There's so many things that are going to be like commonplace now that are just not going to exist in medicine in the next 5 years. And I want to be part of that revolution, really, and being part of the vanguard that kind of ushers that in for our next generation of doctors. Because if medicine is kind of like government, right? Like the tech and the equipment and stuff, like things that we use definitely have that stink of like 30, 40 plus years old, right? So a lot of this field is slow to develop, and I don't want that to happen. Like, I want my hospital or my colleagues or my practice to evolve, right? There's so many aspects about traditional business, right? Traditional industry that rapidly evolve with the technology that's coming out on the market nowadays. And I feel like medicine just insulates itself because it's like, oh, the doctors are so stubborn, or the system doesn't want to make it work. But clearly, like, you don't have to be Silicon Valley to understand that business intelligence and data science is going to help medicine. It's just, can you trust a doctor to learn these things and train them in these things and become a leader in this area instead of, letting Claude make those decisions or something, right? Saiken, did you do debate in high school? Debate is life. I was a Lincoln Douglas nerd. Hey, Saiken, do some INISET questions sometimes. It's a postgraduate entrance exam in India. Why would I do an Indian postgraduate entrance exam? What the fuck? I have to recertify my American boards in 4 years. Why would I bother doing Indian questions? What do you think about biomed engineering? Is it a good career to pursue? I'm studying engineer, but I haven't chosen a specialty yet. I don't know. I'm not an engineer, dude. I have a video out on, how to become a doctor, or at least for the Americans, I have a video out on how to become a doctor. And there is a lot of pre-med counseling in there, specifically for like the juniors and seniors in college. And a lot of it is based on my experience in med school. I worked on my student admissions board, and I did private med school admissions consulting as well. So I do have some experience with, the back end of that system and the things that I personally would have looked for and the things that I personally want to see out of applicants. So, if you are in high school or college or something and trying to look to get into medicine, I would definitely recommend that video because it does have kind of like the ethos of what I believe a good pre-med applicant should be. So different countries got different sets of knowledge. It's not just different sets of knowledge, it's just like the standard of care, right? And like the different practice standards, different way that we treat different conditions, right? Like the sets of knowledge is like the medicines are, the mechanisms of actions are the same. Like, we're both going to use ibuprofen for something, right? But it's just the way that they treat different medications. What do you give first? What do you give in this situation before you give something else? Just the things that we do in America might be different than the things that we do in India. So yeah. Howdy from respiratory, howdy. I'm all in for ushering new systems in tech, but with AI controlled by tech bros who just want to sell our information, I worry about privacy. Also, I see AI make gnarly mistakes often. Exactly, and you need somebody who's fluent in both of those things in order to make that happen, right? So that's, I took a machine learning class last semester. Like, I am slowly trying to introduce myself into that world. But I think just somebody like, as I guess a younger millennial, older Gen Z, like somebody who grew up with the internet and was like comfortable using computers and, is chronically online as a VTuber now, right? Like, I'm a lot more comfortable with leveraging tech and making it work for me rather than adapting my clinical practice to accommodate the tech, I can do it as a millennial straddling those worlds, but yeah. When did you graduate like school? When did you finish fellowship? Because like again, like I'm in my fellowship right now, but I'm an attending, and like out of our practice group, I'm the youngest still by far. Like it's at like a decent like mid-sized academic program. Like it's in the city and everything, but I feel like most of the hospitalists like are balding or have kids or something. And I'm just like, oh, I'm baby. Here's a dumb question. Should I take a biostats elective in college? Probably. I mean, biostats is super helpful. Yeah, it's not going to feel helpful now, but eventually you're going to need it. Eventually you're going to need it no matter what. 2015? Oh, you are much older than I am. So that's 10 years? Dang. You are not Gen Z, sir. Take that back. You remember where you were on 9/11? I was in kindergarten. Like I remember where I was like at home when they like brought us all home like immediately, but like I don't I don't remember anything about it. I don't know. I mean, it's just weird because medicine, I went to a med school where a lot of my class like med school average age in America for an incoming like M1 is like 24 or 25 now. So like for me straight out of college at 22, like my classmates were already a bit older than me. And I think most of my friend group was like a solid, 2 or 3 gap years in before they went to med school. And then, when I went to residency, like all of my colleagues were definitely older than me. Like some of them had like kids and stuff. And like one of my colleagues was like 40. Like he already had like a whole career on Wall Street as like an iBanker or something before he switched to medicine. So like I just always had this chip on my shoulder for just like being one of the younger ones in the class and just like not hanging out with anyone else because like nobody cared about me. Everyone had their own lives. Everyone had their own families and their kids and shit to deal with. So like yeah. Over here in Australia, the youngest student fellow in primary care is like 29. For IM, it would be like 32, 33. Yeah, so I started residency when I was 26. So yeah. Well, actually, I mean, I think in India it's even younger, right? Because I think in India it's like you do 6 years of undergraduate, and that's like combined with med school. So you do residency after that. Because we had one Indian intern who came in, and she was like 23 or something. And I was like, what the heck? I'm like, do you know like how to pay your taxes? That's how it works in the UK. It's how it works in Asia too. Or I guess India's part of Asia, East Asia, because I have a cousin in Korea who's doing the same thing, and she's 22 right now, and she's only halfway done. Like she just started her like med school curriculum part of that. 23, that's impossible. I don't know, she like skipped grades or something. What are your thoughts on open evidence? Sometimes I feel like it's a bit of a crutch and I might make my clinical skills and critical reasoning worse in the long run. I mean, it's Conan Liu has a very good video on like, is open evidence making doctors dumber? Ideally, you want to use open evidence like how you would call a consult, right? Like you need a clinical question to ask that is out of your expertise, that you need an expert or a specialist to weigh in on. And I use open evidence or like things that I gather from open evidence to talk to the consultant like on their terms and be like, hey, like I understand like ABC, but I want you to blah, blah, blah. And usually consultants do appreciate that. I mean, I don't know if they know that they can tell that I really just read something off of, open evidence and I'm regurgitating it to them. But at least it shows that, I'm thinking on their level and like trying to anticipate what kind of questions that they're going to ask so that, I have some common language to talk about, right? Because there's so many consults where you can just call and be like, hey, like I have a guy, he's got masses in his liver, he's pruritic, blah, blah, blah. Can you come by and stent him? And then the doctor's like, yeah, sure, bye, and they hang up, right? But like you're not, as a clinician, you're not growing like that, right? You're just being a hospitalist, and you're just going like, oh, hey, can you do the thing for my patient? Bye. Right. And I just feel like you're wasting the opportunity of being able to work with so many talented and knowledgeable doctors and specialists. And it's a privilege of IM that you're able to crosstalk with so many departments and, take a bit of GI, take a bit of cardiology, take a bit of IR, take a bit of surgery from here. And right, like how many times is a surgeon going to talk to a gastroenterologist, right? Or how many times is a pulm going to talk to like an endocrinologist, right? And I feel like we should be taking those interactions that we have, with every clinical pearl available and try to get as much as we can from it, right? Saiken Korean, why no StarCraft? Because I'm only half Korean. My mom is Taiwanese, my dad's Korean. I played Zerg growing up. I didn't really get into 2 though. I got pretty red pilled on Brood War by like my neighbor, my childhood friend growing up. But I never really actually got like Diamond in StarCraft or anything. I got League of Legends. All right, I'm Emerald. I'm a support main. League of Legends good. Hi, I'm an incoming second-year med student. Do you have any tips and advice I should look into? Yeah, U-World, Pathoma, Sketchy Micro, and Sketchy Farm. That's it. What's IR? IR is interventional radiology. Interventional radiology, which in America is mostly a procedural specialty where you get, you know, things done, right? Like IR can biopsy nodes for you. IR can put in like advanced access for you. IR can, you know, place, I don't know, things like nephrostomy tubes, right? Like really detailed procedures that need the fluoroscopy involved. That's what IR is there for. And, you know, for what I was talking about, it's just like, you shouldn't just consult people and be like, oh, can you do a procedure for me? Because, you know, you have the permission to do the procedure, right? Like you should ask them like their thoughts, and you should understand what the indications for those procedures are and everything. So, yeah. Jadong, oh my God. What is that one Loco Doco quote? He's like, oh my God, it's J-Dong. I want to do coke off of your erect penis. Do you guys watch Double Lift's retirement home tournament yesterday over the weekend? It was so much fun. Like for every like 2015, 2019 like esports unk out there, like dude, they had Double Lift, they had Boy, they had Haunter. It was like some people were posting pictures like pre-2012. Like there was like a really old picture of like Bowl Cut, Double Lift, West Rice, Dyrus, Reggie. But they had so many oldies like Acadian, Maple Streets, Link, Xsmithy. Like all of the boys were there. It was so fun. What's a helpful platform in studying pharma? Sketchy Farm. Sketchy Farm and whatever Anki deck comes with it now. Probably like Pepper. I don't keep up with Anki that much anymore for step 1, but Sketchy Farm 100%. All the elderly league pros, yeah, it was cool. And Froggen was playing. Froggen did the thing where he does a tower dive, they juggle aggro, Froggen turns into Egnivia and then TP's out while taking the tower. And everybody was like, oh my God, whoa, how does he know how to do it? That's crazy. And it's like, guys, if you watch this like old EU LCS video from like 2014 where 2015, Froggen is on Echo Fox, he's explaining his Anivia pocket pick. He literally explains this tech 11 years ago in a YouTube video. And I was like, shit, I'm fucking old for knowing that. Jat and Freak Coat. Yeah, dude, Jat sounded raspy as hell. I don't know why he was so like, maybe he had a cold or something, but yeah. All the names from my college esports watching. Yeah, dude, it was like flashbacks to like playing fantasy with my friends and stuff. Like that was a very good time. Oh my God. Okay, I feel like I've been yapping for like half an hour. You guys want to do board questions? you guys want to do things? All right. This one. Froggenivia. Oh my God, Froggenivia. But 2015's not that long ago, right? Right? Oh my God. What were you doing in 2015? I was in my junior year of college. That was crazy. Talking to the real internet doctor is nice though. Thank you. All right, board questions. Yay, board questions. Dude, this is like my default content at this point. Like why does it always come down to this? Okay, like I swear to God, I will go and play the house visual novel on stream. I don't know when I'm gonna be able to stream next, but I will do the house visual novel for the DS on stream sometime. Maybe Saturday, maybe Sunday. I just randomly remembered it existed and I wanted to go for it. You chose this content? Well, it's not my fault that this content keeps doing so fucking well. Like, out of all of my stuff, like the videos, the shorts, the live streams, like everything everything pops off when you just involve questions or Dr. Dole. I don't know why. Dude, like my Dr. Dole has like 300,000 views on it or something. It's crazy. Yeah. Like they're like Dr. Mike, Conan Liu, like everybody just subscribes to the Dr. Dole meta now. It's crazy. Y'all graduated 2015, not me. I was later than that, I promise. No, it's so much fun to watch genuinely because you're actually really entertaining to listen to. Aw, thanks. All right, let's go. A 30-year-old woman comes to the office due to a nodule in the right lobe of the thyroid gland. The nodule was discovered incidentally on a CT scan of the neck performed 2 weeks ago to evaluate neck pain following a motor vehicle collision. So when they say incidentally like this, like, honestly, this is where I kind of disagree with like concierge medicine or, you know, those full body scans that they do in, I know this is super popular in Korea because my dad was like trying to tell my mom to do it, but they do like whole body MRIs like every year or something, and you pay like $2,000 and you just get a full scan of everything in your body. And it's like, why? Right? Like, if you feel in pain or if you feel like something's wrong, fine, get it scanned. But like, what is the point of subjecting yourself to these stupid yearly baseline scans for the chance that something could be wrong, right? And then it's like, you find something incidentally, you're going to have to follow up on it. And if you were asymptomatic the whole time, what does that cost you in terms of money, you know, the hardship, emotional turmoil, everything? Ugh. It's just like, yeah, trauma pan scan post MVA that incidentally finds the liver mets, right? Like, all right, well, was there any benefit to finding liver mets now versus finding it 2 years later when it would actually been a problem? I think it's like lead time bias or something like that. Oh God, that's probably going to be one of the questions on here now that we're thinking about times of bias. People like to feel they're in control. Dude, have you, can you please explain, you know, as FM, can you please explain this new, like, mammogram, like, system, right? Like, I understand mammography from 50 to 74, right? But why are people asking for baseline mammograms? Like, what does that even mean? Like, do you ever get a baseline scan in anything? Can you imagine being like 35 years old and your doctor is like, yeah, I need to get a baseline colonoscopy on you. Or like, oh, I need to get a baseline laparotomy on you. Like, what the fuck? Baseline. Yeah, wait, type in like baseline mammography or something. See what pops up. It's like, yeah, a baseline mammogram. Yeah, like what? The Texas Health Resources, Stanford Health Resources, Capital Imaging Services, ACR. Yeah, dude, like it's crazy. Like baseline mammogram from 30 to 39. That is just why. Yeah, exactly. I just say this is when we start screening, and why complicate it more? It's the same thing. It's just like the ASCVD risk score, right? Lipids. I want to I will start statins after 40, right? Like, yes, I can start statins before 40. Just evidence shows that like it's really only going to benefit you the most after you're 40. Oh my God. Baseline XLAP. Okay, no. But yes, like baseline mammography is like a thing. It became a thing like maybe 2 or 3 years ago. I don't know if you guys use QRisk. Is that like Q SOFA? QRisk is QRisk 3. Oh, University of Nottingham. I think this is like a UK thing. Oh, you're Indian, right? So yeah, it's probably a UK thing. It's probably just like a screening risk tool. Depends on if we're using USPSTF. Yeah, so I use USPSTF, but I think ACC-AHA wants you to start at 40 still. Isn't it better to be safe? I don't know, I'm not a doctor. Yeah, no, that's a good question, right? Like, if screening tests were literally free for everybody, and there was zero risk of radiation overexposure, and there was zero risks of getting super expensive screens over and over and over again, fine, sure, we could do it. But the reality is that it's not, right? And everything carries risk, everything carries bias. And if you get these awesome pan scans done every year, what is the risk versus reward of just getting it done regularly, right? Did you change your outcome? Does discovering something there incidentally change the management or the trajectory of whatever that thing is? Probably not, right? Like we do screening tests and we have guidelines for a reason, because on a population level, we are able to discover things the way that we do, right? Like this isn't talking about like management, right? Like obviously if something is wrong, then we're going to manage it. But the actual ability to get things done on a timeline where you are discovering things it's incidentally or getting pan scans every year to find something wrong that might not change or might not become symptomatic or might not even matter. It's like doing a cancer screening in like an 85-year-old, right? It's like, well, why are we doing this, right? It's kind of the same logic. It can cause you stress. Yeah, it's like it's financial, it's emotional, it's just not the right thing to do for people. This is a tricky question. This is a TI Rads. Wait, I haven't even finished. Wait, I haven't even finished the I haven't even finished the question yet. Hang on, somebody messaged me. I need to respond real quick. I said TI Rads. I'm like, wait, what are you talking about? And I'm like, oh right, this is a thyroid question, isn't it? Okay, I just told them I'm streaming right now. All right, okay. So she incidentally found a thyroid nodule, right? Wait, I thought old people get cancer. Well, that's what I was saying. It was like screening for an 85-year-old, right? Like, are you going to put an 85-year-old, you know, probably with 3 or 4 other medical conditions, are you going to put them through a whole screening regimen? Like, what is the use of diagnosing cancer in somebody who's 90, right? Like, are you going to be able to safely give them chemotherapy or safely put them through an operation? Like 9 times out of 10, probably not. So why are you looking for things to go wrong and all these things? So, all right. We're not ignoring it. It's more about like the bias of like lead time, like discovery and management and like expectancy after you find the thing. What is a nodule? A nodule is just like a solid bit. Like just, you know, it could be like a cyst, it could be a mass. It's just something that you find on a scan and you're not really sure what it is. Without a biopsy, you're technically not really sure what it is. All right, so she found a thyroid nodule on her right lobe. She incidentally had a CT scan performed 2 weeks ago to evaluate neck pain following a motor vehicle collision. The patient feels well and has experienced no weight change, temperature intolerance, hair or skin changes, or menstrual irregularities. So it's not super hot, right? It's not like it's secreting T4 straight up immediately. She has no chronic medical problems, takes no prescription medications, and has no history of radiation exposure. Family history is negative for thyroid cancer. The patient does not use tobacco, alcohol, or illicit drugs. Blood pressure is 120/80, pulse is 72. Thyroid examination reveals a palpable, firm 2-centimeter nodule on the right lobe. Neck lymph nodes are not enlarged. Remainder of the physical exam is normal. So despite despite the imaging, you have to cut and open or do nothing, right? So this one probably is a question of, do you know how to manage nodules? Like whether you discover something, if it's active or not, what are the criteria where you actually need to do follow-up testing, or if you need to do nothing. So one of these is probably just, so like this one, repeat TSH level in 3 to 4 weeks. That's like the do nothing and reassure option. And then I'm pretty sure for low thyroid scintigraphy is what you're supposed to do next, because this entire clinical vignette, it's an incidentally discovered thyroid nodule. The patient is totally fine. She has no history of thyroid cancer. She has negative on all of these hyperthyroid syndromes, no chronic medical problems. She's 30, she has nothing else going on, right? And she doesn't seem to have any other complaints coming in. But the ultrasound shows a right lobe hyperechoic nodule, measuring that with no evidence of microcalcification or internal vascularity. What is the next best step in the evaluation of this patient? So there is a whole, algorithm to manage thyroid nodules. But unfortunately for her, even though her free T4 is normal, her TSH is still low. So unknown bioboulder. Yeah, unknown bioboulder is actually a pretty good way to explain it, because you don't know what it is, right? Yes, we can do an aspiration. We can stick a needle in there and figure out what it is right now, but do we need to, right? I'm pretty sure it'll show like the full, algorithm or flow chart once you actually get to the answer. But for this patient, because she's totally fine, you might want to think that you just repeat the TSH level and you have to do nothing. But because her TSH level is low, even though her free T4 is normal, I'm still worried that you're still going to need to work this up. I think I did a video or a tweet on this before, but your thyroid gland is basically the gland that controls the on on-off switch in your body. High thyroid means that, you know, you're constantly awake, you're constantly up, your heart rate is going 1,000,000 miles an hour, you're sweating, all these things. Low thyroid is you're lethargic, you're swelling up, you sleep like 20 hours a day, depression, brittle hair, all these things. So having a good balance of thyroid is also very important. And this is like an endocrine organ that a lot of people overlook when they're doing these initial workups. But things like on the differential for a blood pressure problem, always got to think about the thyroid. Things on the differential for like a psychiatric problem like depression, always got to think about the thyroid too. So the thyroid stimulating hormone comes from your pituitary gland. And your thyroid stimulating hormone is secreted when your pituitary gland gets your signals from the hypothalamus that's telling you to make TSH. TSH is going to go to the thyroid and make thyroid hormone, and high levels of thyroid hormone finish a negative feedback loop telling the pituitary, hey, you don't need to make any more thyroid stimulating hormone, you're good. Now the problem is the patient has a high T4 level, or a normal T4 level, but even though they have normal T4 levels, your TSH levels are very low. So the TSH means that the pituitary is getting some sort of negative feedback from somewhere that's telling it, hey, you don't need to make as much thyroid hormone. And because the TSH is low, you would expect the T4 to be low, but it's not. The T4 is normal. So there is something going on here that's causing a wrench in this negative feedback loop where these things aren't adding up. And because she does have a nodule, you're going to have to work this up with scintigraphy. Nice. Actually, yeah. So this is pretty good too, because this one looked pretty split. Half of the people picked scintigraphy and half the people picked FNA, because you actually, you know, yes, eventually you're going to have to, but it depends if this is an active problem or not. So here's their whole flow chart, right? So you do an ultrasound and you find the nodule and whatever. If you have a low TSH, you're going to have to do a scintigraphy, right? And if the scintigraphy shows that there is a lot of iodine uptake and it's a hyperfunctioning nodule, then you just treat it normally. But if it shows that it's cold, which means that it's not taking up iodine, then you also treat it like they have a normal or elevated TSH, kind of like you're doing a hypothyroidism workup. And then you would consider the FNA based on how feasible it is, which, oh shit, oh man. I remember knowing this for boards. I don't remember it anymore, but there's like I made a whole flashcard about this. So for thyroid nodules, another popular one is pulmonary nodules. There's like at least 3 different types and 3 different classes, and depending on the size, like 12 different things to do. So like mixed versus subsolid versus ground glass versus solid, and it's like a whole bunch of things. Is the solid composition not enough concerning to warrant an FNA? It's not that it's not concerning, but it's the low TSH that's more concerning, where you have to do a scintigraphy first, because if the scintigraphy shows you that the nodule is hot anyway, because hot nodules are less likely to be cancerous, you would just treat it as a hyperthyroid case, versus a cold nodule is more likely to be cancerous, and that would be something that you would treat with an FNA and working up a thyroid cancer. Medicine is half flowcharts, half intuition. That too. As a hospitalist, I mean, I don't really have to think about that too much, but I mean, the art of medicine is really understanding what to do with your patients, right? What can they afford? How can you properly work them up with the resources that you're given? At least being a hospitalist, right? If I need to get a test for a patient, like I can order a test for the patient. Like we have the equipment in our hospital. We have, the transport, right? We have a nurse to take them down in the wheelchair to the actual imaging thing and come back, and we get the results in like a few days, right? But the problem is, like, what if your patient doesn't have a car, right? What if your patient can't take public transit? What if your patient, is bedbound? And all of these things that go into medicine is really understanding where your patients are coming from and how you can take care of them the best. Should I biopsy the cystic structure in the kidney? Should I biopsy this umbilical nodule that could potentially seed the entire omentum? All right. A 40-year-old woman is referred for the evaluation of chronic kidney disease. She has a 2-year history of intermittent back, bilateral flank, and central abdominal pain. Okay. She has lost approximately 15 pounds and is easily fatigued. Okay, whoa. Oops. She had an episode of DVT 1 year ago that has not reoccurred, and she has noticed bilateral pedal edema. All right, so she's got back pain, abdominal pain. We already know that she has CKD. So she has some kidney issues where her kidneys are not excreting, waste products as well as they could. Maybe they're not filtering as well as they could, not reabsorbing fluid as well as they could. That's why she's swelling up a little bit. She had a couple other problems. She had a blood clot at one point. She lost 15 pounds and is easily fatigued. I don't know, did she lose 15 pounds in 2 years or like 15 pounds in like a week? Because I think one patient we had last stream, it was like pancreatic cancer, and it was like the patient lost like 10 pounds in a week, and we are like, whoa, red flag, and that one ended up being pancreatic cancer. So yeah, she works in an office, denies using tobacco or illicit drugs. Up until 2 years ago, she felt well and is unaware of any chronic medical problems. So 2 years ago, this all really started happening, and she had this back flank abdominal pain. And really, she's kind of managing it with Tylenol and Advil, but it seems like her kidney disease made things worse, and she's now having diffuse mild abdominal tenderness and lower extremity edema. Okay, this is a lot. To be fair, any health-related career discipline and able to be socially malleable trumps high intelligence. That's true, right? I mean, that's why it's called the art of medicine, right? It's not just applying flowcharts to people and not just trying to shuffle patients through the system as fast as you can, but you're treating patients at the end of the day, right? Dang, she keeps taking ibuprofen. Doesn't that also harm the kidney? Yes, it does. But I'm more worried about this weight loss, central abdominal pain. Like you can be in kidney failure and not have back pain, right? So she's got back, flank, central abdominal pain, 15 pounds of weight loss. She even had a DVT a year ago, cancer. I mean, 15 pounds is quite a bit. So CBC, hematocrit's fine, leukocyte's fine. So creatinine's 2.2. She has CKD. We already know that. Urinalysis, she's not spilling protein or blood. She doesn't look like she has a UTI, but she's some red blood cells, some leukocytes. She's got pretty decent inflammation, acute and chronic. So, oh, Jesus. All right. On renal ultrasounds, both kidneys measure 12.5, so they are a little bit bigger than they should be. There's bilateral clubbing and mild to moderate dilation of the calyces without dilation of the mid or distal ureters. So she has dilation of the renal calyx, or that's part of like the little pyramids that empty into the renal pelvis, without dilation of the mid or distal ureter. So it's not really a kidney stone, right? I wasn't getting that picture either. And it's not like things are backing up. It's more just like the interstitial tissue in the kidneys themselves are squeezing against the calyces, maybe? If someone with thyroid nodules was treated for hyperthyroidism, would it cause the nodules to shrink? Depends if it's a hot or cold nodule. It depends. So that's the point of the scintigraphy. That's actually what that question was, right? So it's does treating the nodule like it's just a hyperthyroid patient adequately address the nodule, or do you need to do a further workup with a biopsy and worry about a malignant transformation? So that's why for that question, scintigraphy was the first step, because the patient had a low TSH and normal T4. You would have to do a scintigraphy in order to determine if that nodule was taking up a high amount of iodine or not really taking up an iodine. B or C? I kind of like C. I don't know. Okay. This is such a zebra diagnosis, but this is the only one that really explains everything. Maybe you can say cervical cancer. B and C talk about her kidney issues 100%, but they don't talk about the amount of pain, weight loss, and the fact that she had a DVT a year ago. What are calyces? The renal calyx is basically just like the part where like the glomeruli kind of empty into. It's like the renal pyramids, like they dump into the renal pelvis and dump into the ureter. So it's part of like the slide where everything goes down. Glomerulonephritis also has nephritic syndromes. True. But I'm not really worried about a nephritic syndrome per se. I mean, she doesn't have frank blood. She's got like 1 to 2 red blood cells, not any protein, right? I mean, it doesn't think I don't think it's really glomerulonephritis. What I think this is retroperitoneal fibrosis. And this is something that I only know because my nickname for Hero on Discord is retroperitoneal fibrosis. Because one time she was sitting in like morning report with us or something. She's like, why the fuck do these interns know what retroperitoneal fibrosis is? Retroperitoneal fibrosis is a consequence of IgG4 disease. And is something that can also be associated with chronic pancreatitis. So E actually. I think her back pain, her central abdominal pain, her weight loss, and her DVT, and honestly, even a little bit of the pedal edema is explained by RPF. And she also has CKD, and all of this is just her CKD, right? CKD is not going to cause your CRP and your ESR to be that elevated. CKD isn't going to cause that amount of central abdominal pain. CKD isn't going to give you 15 pounds of weight loss, right? So I think this is just IgG4 disease. I don't have a good reason to say that it's not cervical cancer because like, what if it is cervical cancer, right? Because it's cancer. I think like at the end of the day, I'm just trying to say that this is like an inflammatory process with like multiple organ involvement. But I think our PF is like screaming a lot more. Oh, 44%. Okay, yeah, 25% of people said it was cervical cancer with spread into the broad ligament. So this definitely like was a thing on people's differentials. Why does RPF cause weight loss? I mean, because you're basically just in the setting of constant inflammation and malignancy. It's like pancreatic cancer, right? You're just gonna start like wasting away and stuff. The different units are throwing me. What is CKD again? CKD is chronic kidney disease, which, you know, just as a function of your glomerular filtration rate, like means that you're just mildly impaired with how your kidneys are functioning. 6'7", 6'7" millimeters. And that takes a lot of energy. Yeah, exactly. Wow, this was crazy. I don't know. Would I have gotten this on boards? Probably not. Like, retroperitoneal fibrosis is such a random diagnosis. Like, I would not think of approaching anybody as RPF as like the first thing going on. Like, this lady is totally fine up until 2 years ago, and then coming into your office for referral for CKD. Like, and then she's gonna walk out of that. She's gonna walk out of that encounter with a diagnosis of RPF. Like, what? What the heck? I don't know if I like that. Here's what it says. Patient's presentation is most consistent with retroperitoneal fibrosis, a rare disorder causing mid and distal ureteral obstruction without the usual ureteric dilation seen in obstructive uropathy. So obstructive uropathy, that's what I was saying. It probably is not a kidney stone or something obstructive because the actual ureters aren't dilated. RPF is usually idiopathic, but has been associated with drugs, malignancy, infections, and radiation therapy. RPF is the result of chronic inflammation with fibroblast proliferation leading to chronic periaortitis and involvement of surrounding structures. So yeah, that's really what I was saying with, you know, why she's so inflamed, why she's losing so much weight, where all this pain is coming from, etc., etc. I'm pretty sure I would have only gotten that because I nicknamed Hero RPF, and that's just like been sitting in our Discord for like 3 years now. It's like, you don't know that IgG4 disease is associated with chronic pancreatitis and RPF, and she was like, shut the fuck up. All right. 46-year-old man with known kyphoscoliosis. Okay, so his spine is like bent forward. Complains of fatigue, or what is it? Hunchback. There we go. Complains of fatigue and progressive shortness of breath over the last year. He can barely walk a block without becoming short-winded. During his last evaluation, his vital capacity was 40% of predicted value, and his FEV1 FVC ratio was 85%. So, yeah, there are lung diseases like COPD or, you know, pulmonary fibrosis. And then there are actual like mechanical diseases like severe kyphoscoliosis, which is hunchback, or lordosis, which is like swayback. And this is literally just like the actual physical chest space that your lungs have is not enough to adequately expand your lung tissue and all these things. Honest question, as someone with no medical knowledge, isn't the problem with most cancers is that they cause so many different symptoms at different stages of progress? Yes. So for me, my dad has lung cancer. He has stage 4 lung cancer, which, you know, sounds terrible on paper, but he's fine. He's stable on chemo and everything. Lung cancers are extremely hard to diagnose because patients don't feel symptomatic up until anything happens. And for him, his symptom was jaw metastasis, where he thought he had TMJ, he thought he had a bunch of problems like parotitis or a bunch of, you know, like bone problems from grinding his teeth in his sleep, that he had jaw pain. And eventually, after working it up, they did an x-ray that showed like localized bone destruction, and then that x-ray showed like it captured like maybe like the top right part of his lung, and it showed that he had a mass in there, and that's how he was diagnosed with lung cancer. So they are hard to find because, you know, patients might be completely asymptomatic up until they actually complain about symptoms. And even though he was diagnosed at stage 4, I mean, he did get lucky. He was put on the appropriate chemotherapy, and he did pretty good. Actually, he was on, is it immunotherapy? Well, I don't know what the actual correct name for it is. It's a tyrosine kinase inhibitor. He was on osimertinib, but it inhibits the exact like VEGF factor that he had for his lung cancer mutation. And it was actually like an oral pill, and he was stable on that for like 2 years. So cool. Oncology. I don't know. He was like asking me like, have you heard of these medicines? Like, do you know what like these trials are? I'm like, Dad, I'm a hospitalist. Like, I'm sorry, I do not know your cutting edge chemotherapy that you're getting. And he's like, what kind of doctor are you? I'm like, what the fuck? Dude, such an Asian dad moment. All right. So this guy has pretty severe kyphoscoliosis, which means that like his ribs probably are not letting his chest expand as much. So this is a bucket handle problem. Like his ribs don't actually allow for his lungs to expand and he'll breathe properly. Pocket, thanks. Saiken MD, someone is asking for the Discord. There's a command. There's a command on Twitch. Just do that. Yeah, there we go. There you go. Pocket, thanks for the raid. How are you doing? We're just doing board questions. What is a tyrosine inhibitor? Tyrosine kinase. So it's a specific type of like growth enzyme where things like start proliferating. And for the type of lung cancer that he had, this medicine specifically targeted that certain enzyme and prevented it from growing larger. That's basically what it is, TLDR. All right, so like I was saying, this is a bucket handle problem. He's got reduced vital capacity because his lungs just don't expand in his chest. And it's not necessarily a COPD problem or a restrictive lung disease problem, but it's like a physical mechanical problem with his chest wall expanding. I hope you have the best time. I have to eat something, so I'll be lurking. Okay, thank you. All right, patient's blood pressure is a little high, but it's okay. Oxygen saturation is 90% on room air. The angle of scoliosis is 65 degrees, and kyphosis deformity is above T10. Yeah, so it's definitely, it's definitely getting his ribs. Angle of scoliosis, I don't think there's a number for kypho. I know for like scoliosis, like normal, like when you're doing like pediatric screening and like teenagers and stuff, they monitor something called like the Cobb angle, which is like the perpendicular intersection of like the spine and like the largest deviation from the center. And that's what they measure. But I think angle of scoliosis in this case is mostly just talking about the front to back angle. Transthoracic echocardiogram shows normal LV function, mild right ventricular enlargement, and an estimated pulmonary artery systolic pressure of 55. Okay, so he's got some right-sided heart failure, or at least right-sided heart problems, based on the fact that his pulmonary vasculature is not flowing through correctly because he has so much chronic pulmonary disease. But it's not really COPD or something from like smoking. It's really just like a mechanical problem. So, I mean, I think somebody said it already earlier, but I would probably just go with intermittent non-invasive ventilation here. I don't think inhaled corticosteroids are going to help this guy because it's not really an inflammatory problem. Long-term anticoagulation, I mean, it's not really a clot problem. Like, he doesn't really have a clot burden either. It's all mechanical, right? Like, you know, if this guy did not have this severe kyphoscoliosis, he probably would not have these problems, but his back and his current like angle of scoliosis is really what's driving most of these problems. Yeah, so it's alveolar hypoventilation, and you would fix that with intermittent ventilation, right? So you wouldn't need to give him vasodilators or corticosteroids. You wouldn't need to give him anticoagulation in this case because you can just fix it by fixing the mismatch here. Bracing. Bracing is interesting. I'm pretty sure you're not supposed to do bracing. Yeah. Bracing may be used in idiopathic scoliosis for skeletally immature adolescents, but is contraindicated in adults. I'm surprised so many people picked that. I'm surprised 51% of people picked that, because that's, you're not supposed to do that in adults. Not to hijack the stream, but I joined and accepted the server TOS, but I can't see general chat or anything. Okay. Every time I drop the Discord link in stream, so many people join that it that it ends up like overloading the bot, and it can't do its like normal verification stuff, so it gives a warning that it says that you're getting like hate rated or something and it wants you to like review each manually. That has not fired yet, actually, so I'm not sure. I would give it a bit. It's YAG bot, so make sure that you don't have YAG like blocked or anything, but yeah, it should work in a bit, maybe. Oh, thanks, Pug. All right, yeah, I think this was pretty much just like a do you know what to do in this case. I'm not sure why so many people picked bracing, because 100% bracing is wrong. Like, have you ever seen an adult in like a scoliosis back brace? No, like you're getting rid of their compensatory mechanisms. What the heck? All right. 33-year-old man comes to the emergency department due to a 2-day history of left knee pain and swelling. The patient has not had similar symptoms before and reports no preceding trauma, pain in other joints, skin, rash, fever, or chills. So we got left knee pain and swelling. Could be like a reactive arthritis. He's 33, maybe he's sexually active, gonococcal arthritis, etc. Med history is only notable for seasonal allergies, which he takes loratadine as needed. So patient does not use tobacco, alcohol, or illicit drugs, so otherwise pretty healthy. Yeah, kypho is pulmonary hypertension with no parenchymal disease. Yeah, so like treating it like a pulmonary disease in itself isn't going to do anything, because it's not like he's COPD, it's not like he's restrictive or anything. Cock arthritis, gonococcal arthritis, so gonorrhea causing like a reactive arthritis. Yeah, you have to get a CAPTCHA from YAGBot, which is why I think some people might have YAGBot blocked or something because of spam. So if you have a DM from YAGBot, I think you need to solve that. I don't know. You know, like my Discord channel, my Discord server literally had 2 channels for like 8 years, and then I actually popped off or something in the past couple of months, and I actually had to make like a real Discord server. And it actually had to like get mods and stuff to do things. Do doctors snitch if you take illegal drugs? No. Please watch my video on herbal supplements and like the entire section on what I report and what I don't report, right? I report things like child abuse. I report things like elder abuse, right? I do not give a shit if your urine turns up positive for cocaine or drugs or whatever. Right? It just changes how I treat you in the hospital, because there are certain medications that I can't give you if you have certain substances in your body already. I do not go to the police or call your boss or whatever and tell them that your urine tested positive for drugs, whatever. That is a HIPAA violation. All right, so temperature is 98 degrees, blood pressure is 110/56, pulse is 78, respiration is 14, BMI is 22, so he's totally fine. But his physical exam is a moderate left knee effusion. It's slightly warm, but it's not erythematous, so it's not really super red or swollen, and there's no locking of the joint or ligamentous laxity, so it's not like a meniscal or ACL kind of tear or anything. Labs look fine, okay. I think, what is a normal ESR? I think his ESR is fine. ESR is... Oh my god, where is ESR? Bruh, where is ESR? 0 to 15? Oh, okay. So ESR is slightly elevated. So he's got some more chronic inflammation over the past 2 days. X-ray of the left knee reveals linear calcifications of the menisci and articular cartilage with moderate effusion but no fracture. So he has calcifications. So now I'm thinking more of like a gout, pseudo-gout kind of angle. Ooh, okay. Synovial fluid analysis shows leukocyte count of 15k with 80 neutrophils. Gram stain shows no organisms. Crystal analysis is pending. Boo! The lab should have done crystals by now. Yeah, Zareth gets it right. It's CPPD. I think this is pseudo gout. This is. Ooh, God, is it iron studies? Is it iron studies? I mean, we have the diagnosis, but it's like, which of the following of the most additional tests is most appropriate to evaluate? That's so stupid. God. It's not anti-CCP because it's rheumatoid arthritis, ANA, double-stranded DNA, HLA-B27 testing. So this is going to be for ankylosing spondy. This is going to be for like lupus, and this one's going to be for rheumatoid arthritis. Hi, Saiken in chat. I got accepted to Magic. Congratulations! Congratulations! I'm gonna say, right, like, you would think that uric acid level corresponds with gout versus not gout, but I don't think it's uric acid level. I think it, yes, hemochromatosis. I was just about to say that. I think you do the iron studies first before you figure out why they have pseudo gout. Yeah, it's hemochromatosis that causes them to reduce clearance of CPBD crystals, and that causes them to deposit in the joints. There we go, yeah. So serum uric acid level was like the second most popular one, definitely. So uric acid levels should not be drawn during an acute attack, as they might be misleadingly normal. So this one is more of an inflammatory arthritis, but it's an inflammatory arthritis associated with the fact that he has calcium pyrophosphate crystals depositing in the thing. Chondrocalcinosis emerges due to hemochromatosis. Yeah, that's why I was thinking, like, why you do the iron studies first, right? Because like I think we had the diagnosis already, and it was gonna be like crystal analysis is pending, but it would have been like fucking envelope shaped crystals or whatever, right? So definitely, like, it's not enough to know the diagnosis, but it's also like, know which other step could you order in order to get the diagnosis if you didn't have the crystal analysis ready or something. I don't know. But this one, yeah, I can't give you a good reason for why I knew uric acid level was wrong, besides the fact that, one, you don't draw the uric acid during the attack, and two, that it's not going to tell you how it differentiates between gout and pseudo gout. I only know what neutrophils are because of cells at work based. Were there any clinical presentation of the hemochromatosis in question? No. He doesn't have any symptoms of iron overload or, what is it called, bronze diabetes or need for recurrent phlebotomy. I mean, he's only 33. He's got no medical history, etc. But you have to work up his pseudo gout. And in the context of a pseudo gout workup, you need to know what is causing the pseudo gout. So what they're asking is, you are going to have a pseudo gout patient. Do you know how to work them up? It's not necessarily about diagnosing this 33-year-old guy, right? This 33-year-old guy might not even have hemochromatosis, but he actually has an inflammatory arthritis. And do you know what are the steps of diagnosing an inflammatory arthritis? One of them is taking a look at pseudo gout and making sure that hemochromatosis is not the cause of the pseudo gout. So that was a little hard. What difficulty level are these questions? Step 1 or step 2? This is like step 4. This is the American Board of Internal Medicine. So this I stole this question bank from one of the third-year residents that works under me, and I was just like, hey, can I just like mess around on this? And he was like, sure. So step 1 you take after your second year of med school. Step 2 you take after your third year of med school. Step 3 you take after your intern year of residency. And then boards, which is what this is, you would take after graduating residency. So this is a while. Hypothetical question. If for whatever reason you experience back pain due to something like DJD, you have a doctor who refers you to the clinic for an epidural. The epidural makes the pain from the affliction worse. The doctor who gave the referral no longer works at that office. In your professional opinion, what would you do? Okay, wow. Degenerative disc and going straight to an epidural is a little crazy. All right, but I would definitely say try to find the so I would not go back to the clinic. I would find a new primary care doctor and establish care with a primary care doctor and look for a new referral. Because one, I don't even know what an epidural would have done for disc disease, but I don't do epidurals, period. So yeah, that's I think if the doctor doesn't work at that office anymore, no point in trying to go back. Just establish care with a new one. I just took step 1 and I have my first rotation in IM, and somehow I found your channel. Hope to learn a lot. Good luck. All right, I think we spent enough time on this one. Ooh, is this a sleep hygiene question? Oh boy, okay. A 40-year-old man comes to the office due to sleep difficulties over the past 2 years. He regularly goes to bed at 11, but is unable to fall asleep until 12:30, so that's like an hour and a half. As bedtime approaches, he typically becomes tense, watches the clock, and worries about the prospect of another sleepless night. The patient eventually falls asleep and awakens by alarm by 6 a.m. in order to arrive at his office by 8 a.m. During the day, he feels fatigued and is concerned that his insomnia is negatively affecting his work performance. The patient does not take naps during the day. His wife has not noticed any snoring, unusual limb movements during sleep. General health has been good and he takes some medications. He would like to exercise, but he feels too tired. Okay, so this is really a sleep hygiene question, but it's like a very esoteric sleep hygiene question because it's not like the normal ones. Maybe it's almost like an anxiety kind of thing, right? Like as bedtime approaches, he typically becomes tense, watches the clock, and worries about the prospect of another sleepless night. Yeah, right? It is more so psych related. It's not... Okay, so I mean, I'm not gonna... It's never napping. It's never napping. Recommending restricting time in bed to 5-6 hours a night. I mean, he already spends like 6 hours and 6 hours a night in bed anyway. Recommend going to bed only when feeling sleepy. I mean, this is pretty valid too, right? Like if you're tired, go to bed, and if you're not tired, not go to bed. I think it's psychophysiological insomnia because of the maladaptive association and conditioned anxiety. Yeah, right. The conditioned anxiety with the watching the clock and worries about the prospect of another sleepless night. Like this part makes me think it's like something psych related more than just sleep hygiene. But I feel like recommend aerobic exercise before going to bed. I mean, it makes you sleepy, I guess. Advise remaining in bed, doing a relaxing activity even if unable to sleep. Is a relaxing activity good enough to treat this sort of anxiety? I don't know. I know B helps me. Not supposed to do activities in bed though, right? It's like you're only supposed to use bed for sleeping or something. Advise remaining in bed, doing a relaxing activity even... No, I feel like... Isn't it almost just like you're not supposed to be in bed, right? Like you should associate, like that's the thing that they always teach you in college, right? Bed is for sleep and for sex, and that's it, right? Because if you like do your homework in bed, or if you watch TV in bed, you associate being in bed with not being sleepy because you're doing an activity in there. Dude, this is so stupid. I don't know. I know what the diagnosis is. I just don't know what this question wants from me. Exercising before going to bed can make him more awake. Yeah, I don't think this is it. I think aerobic exercise before going to bed, I feel like is such a trap, because I think the correct recommendation is like you need to do the exercise like an hour before you get ready for bed or something. Like it's not going to bed, it's before you get ready for bed. So I think it's D, honestly, because I think it's like you only go to bed when you're sleepy. And if you're sleepy, you'll fall asleep. But if you stay in bed, you're going to get tense and watch the clock and worry that you're not getting enough sleep. So that's why you shouldn't stay in bed doing an activity even if you can't sleep. But then recommending restricting time to 5-6 hours a night also feels like maybe he needs less than 5-6 hours a night, right? I don't know, because he has to get up at 6 a.m., which makes him anxious, which is why he's not sleeping, because he's like, oh my god, I have to get up so early. So he tries to go to bed at 12, but he can't really. So what would be the diagnosis? It's like a psychological anxiety insomnia kind of thing. Psychophysiological insomnia there. I'm gonna say D. Okay. That was not a great question. I didn't like that. The question was fine. I didn't like the answer choices. Why can't you just give me like a normal sleep hygiene question? He's chronic insomnia from associated of the bed and bedroom with fear of not sleeping. How young are you? I'm 31. Stimulus control, yeah, so you only go to bed when sleeping. Bed for sleep and sex only. Exactly. That's what they taught me my freshman year in college. That's what I have to teach this patient. You sound 20? That's fucked up. It's okay. I look like I'm 22. Like patients like don't know how old I am. Like they think I'm like a med student or like a volunteer or something. I'm like, no, I'm your doctor. And they're like, oh, okay. Like in residency, like I think I had an attending that was like, oh my god, it's so cute. Saiken, like they always think you're like a kid or whatever. I'm like, no, it's fucking annoying because they don't listen to me. And then she's like, ah, whatever. Yeah, it's a compliment. Don't worry about it. Don't worry about it. And then like we had like 4 patients that day that said it back to back to back to me. And like the first like 3 times she was like, all right, it's kind of funny. And then it's like 7 patients told that to me in a row. And then she was like, all right, it's probably a pain in the ass. That's the problem when you have a baby face. I mean, it's just like being Asian. Nobody knows how old you are until you turn like 50 and you suddenly like lose 5 inches and go bald. And then all of your hair goes to your facial hair instead. Oh my god, is this you world? Don't worry about it. Don't worry about it. It is nondescript, undisclosed board review resource that I stole from a resident who works under me. That may or may not rhyme with poo girled. It's okay, little bro. I went to a Mexican restaurant last month and I ordered a beer and I got carded when I handed to my license and she said, "Oh wow, U Earth." Yeah, it's U Earth. W Earth. Don't worry about it. All right, 65-year-old woman with a history of COPD is brought to the ICU after being intubated in the ED for severe respiratory distress. Intubation is difficult to perform and required 2 attempts. Okay, she has 3 exacerbations in the past 2 years that required hospitalizations, but has never been intubated before. Her medical problems include rheumatoid arthritis, hypertension, moderate obesity, and a TIA. 3 years ago, she smoked 1 pack of cigarettes for the past 40 years. Okay. So she's got a lot going on. So she's definitely, this is a COPD exacerbation. She was in respiratory distress, super acidotic, intubated to protect, and it required 2 attempts. She's never been intubated before, but she's had multiple exacerbations over the past 3 years. And she's got a bunch of other things going on. Examination reveals diffuse, scattered wheezes and decreased aeration throughout the lungs. She started on high-dose methylpred, bronchodilator inhalers, and antibiotics. And she got neuromuscular blockade with pancuronium for 1 day due to severe agitation and patient ventilator desynchrony. So this is like an ICU thing, but you know, if you're fighting the vent and you're adequately making sure that they're blowing enough CO2 and getting enough oxygen, you can use neuromuscular blockade by paralyzing them for a day in order to make sure that they're actually getting ventilated properly rather than try to wean them off early. Hey, I think I know why she has pulmonary problems. Yeah. Like, smoked 1 pack per day for the past 40 years, even though you already know you have chronic pulmonary disease, even though you already know that you had 3 exacerbations in the past 2 years, ma'am, please. Get her some Chantix. Get her some varenicline. Good lord. So much unneeded info on these questions. What is which of the following is the most likely cause for okay, yeah, obviously. All right, so she had a crazy ICU course. She got intubated. She had neuromuscular blockade. On the 5th day of hospitalization, she had markedly improved breath sounds with occasional wheezes, but weaning attempts with pressure support ventilation on the 5th and 6th days were unsuccessful due to low tidal volumes and tachypnea. So they're having trouble weaning her because she has marked muscle weakness in all of her extremities, and her exam shows decreased muscle tone and absent DTRs. Sensory exam is indeterminate, probably because she's intubated, and she's got a CK of 980 and normal hepatic and renal function. So why did she fail weaning? Is it because of the neuromuscular blockade, or did she somehow develop a new Guillain-Barré syndrome? Which I think this is only there because absent DTRs and they're trying to get people to like jump on that. Is it rhabdo? Is a 980 serum CK really going to be rhabdo? No. Is it cervical myelopathy? I mean, no. She's just intubated, right? So I think it's just critical illness myopathy. 1 day of pancuronium is not going to give you prolonged neuromuscular blockade symptoms. I mean, you do see this in ICU. Like it is very common for critically ill patients to develop muscle weakness, and serum CK of 980 is not high enough for me to call that rhabdo. So the options aren't shown, but I'm going to take a big fat guess. It's critical illness myopathy because of the methylpred and pancuronium, yeah. Would rhabdo have normal renal function in this patient? Depending on how good her kidneys were. Obviously, she has a high CK, but it says normal renal function. So even though she has a high CK, her kidneys are still fine and are getting enough fluids to flush out all of that creatinine. So yeah, I'm going to go with critical illness myopathy. I'm going to say rhabdo is a trap answer from the creatinine kinase. Guillain-Barré is a trap answer from the DTRs. Prolonged neuromuscular blockade is a trap answer. So yeah, there we go. You can do a diaphragm ultrasound to guide the timing for weaning. Ooh, that is such like an international doctor thing. Damn, I really wish more clinicians integrated ultrasound into their practice besides just like volume assessments. Like, there's so many cool things that you can do with ultrasound that just like, even a lot of like ICU I've never seen a diaphragm ultrasonography in order to guide timing for weaning. Like, that sounds really fucking cool. And like, I wish we could use that. But I don't know if I've ever worked with an intensivist that knows how to interpret that. That's crazy. Good night, Dubbeast Doctor. I don't like the use of lorazepam here since it'll accumulate in the fat tissue. Oh, they give her lorazepam? Oh, she was on a lorazepam drip for sedation for 3 days. Oh, goodness. Oh, goodness me. What does the timing for weaning mean? So they're asking you, like, this is day 5, day 6 of being intubated. Obviously, you can't keep somebody on a ventilator forever, right? The goal is to get like patients good enough on the ventilator so that you could eventually wean them off the ventilator, extubate them, take the breathing tube out so that they can breathe on their own. The problem with this patient is that she can't do that because she has like global muscle weakness. Diagnosed a few retinal detachments with the assistance of POCUS. I did a video on retinal detachment. So I had one case, this is like back in February or March, I had one case of retinal detachment, and the only reason I knew to do that ocular POCUS exam was because I had this exact case in residency with like the same presentation. Like, literally, this fucking ER tries to admit a stroke workup, which they say like, oh, the patient has like, you know, vision loss in like the same upper right quadrant or whatever. And then I do my exam and he's like, it's not like the quadrant, like I just can't see out of my right eye. And I'm like, huh? So then I do the POCUS and like his retina goes like, boing, 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 boing. I'm like, all right, get me off though. We used it during COVID times in our thoracic hospital. Dang. Ooh, I mean, COVID times in a thoracic hospital, that must have been crazy. I had a retinal detachment, 5 motherfucking surgeries, baby. Yeah, who was it? Was it Sharkovit? I quoted one of my friends in that video because she actually had the gas pneumopexy, which is like they take sulfur hexafluoride gas and they inject it into like the superior part of the vitreous, and the gas, like the pressure differential, basically like seals the retina back against the back because she failed buckling or something. But yeah, that was crazy. I can't do eye surgery. I don't like thinking about eyes. Why are we thinking about eyes? Nothing here has to do with eyes. All right, 82-year-old woman comes to the physician due to sadness, anxiety, tearfulness, insomnia, and weight loss. Okay. She lies awake at night worrying and has no longer any interest in her usual hobby of playing bridge or grandchildren. All right, so she's depressed. She's lost 15 pounds over the past 2 months. So probably from not eating, and physical exam, including lab results, show they're normal. Okay. So this is just a question of, do you know an appropriate antidepressant to start? I don't think there's really a good way to explain this other than like, you want to avoid tricyclic antidepressants in elderly patients because of Beer's criteria. It's not good for them. There's like a list of like 15-20 meds that we do not give to people over like the age of 80. Know anything on osteopathy? No, I'm saiken MD. I'm not saiken DO. I don't know anything about OMM. There are a few DO Dr. VTubers out there. King Bry is one. Actually, he's still a med student. Alu is one. A couple of the Americans are DOs. But I'm an MD. But yeah. Wellbutrin on granny that's not eating, SMH. Yep, so bupropion is definitely out because low when you're at risk for weight loss. Wellbutrin also increases your seizure or decreases your seizure threshold, so you don't want to do that. Olanzapine, not really going to do anything for depressive symptoms. So for somebody that I'm diagnosing with this, I'm going to start Remeron on them. Also helps you eat more, also helps you gain weight. And there we go. So yeah, I think I went through all these. That was pretty good. TCA's increased sedation, which increases fall risks for older adults. Yeah. Can I still use WebMD for research? No. No. OB-GYN. OB-GYN why? All right. A 32-year-old primi-gravid woman, so a first-time pregnant woman, 32-year-old primi-gravid woman at 36 weeks gestation comes to the office for consultation regarding abnormal test results. The tests were part of an evaluation for burning epigastric pain that radiated to the chest and has since resolved without treatment. Make a medical directory of medical tubers, VTubers. I got you. I think I have a tweet about it. Is it here? No? Fuck. Damn it. Where? Guys, can somebody find that tweet? I tweeted a list of like the 12 of us or whatever. God damn it. Bro just finished my IM residency and preparing for ABIM in August. This is a good choice of stream on the treadmill. Good luck. I finished last year. This is just something that I have for fun. Twitter search is dead. Fuck. Man, it's literally like a whole ass post on other Dr. VTubers and I can't find it anymore. I wonder if I can just oh, here we go. Here. I found it. What's malaise? Malaise is just like general fatigue, like feeling unwell. Random medical fact on IUDs. Fun fact, did you know you can use the copper IUD as emergency contraception if you insert it within 5 days of unprotected sex? I did a video on IUDs and I did a video on emergency contraception too. Actually, both of those videos on female genital anatomy and emergency contraception both talk about IUDs. If you're interested, there you go. All right. Fatigue based. Okay, yeah. Sounds like classic depression as opposed to non-classical depression. Are med doctors, hospitalists allowed to diagnose, treat more psych-related diseases, disorders? Yeah, so as internal medicine, I am pretty much like the first line for these issues, right? Like I would be the first person to see them or treat them. And even if a hospitalist is treating depression, like they can still evaluate the patient and diagnose depression. If you understand, the basics, like it is not outside of my scope to start a medicine like Lexapro or Prozac on a patient, right? Like I can still diagnose, I can still manage SSRIs. Personally, when you're actually talking about psychiatry, like I'm not going to go and do like a full therapy session with the patient, right? Like I'm not able to like actually understand depression from a psychiatric standpoint, but from a medical standpoint, it's within my locus where I can prescribe these medicines. Then I would refer to psychiatry if the patient doesn't improve. So I would say like, hey, like I've tried sertraline, I've tried citalopram, like patient's not responding. I can try Wellbutrin maybe, but I think I'd be more comfortable referring this patient to psychiatry because there's probably more than just like a major depressive disorder going on. And then at that point I would refer. But even when I was in residency doing primary care clinic work as part of our continuity clinic, I was still seeing like uncomplicated, the college kids, 20s, mid-20s, and treating them with antidepressants. I would probably not actually do the things like Abilify, right? They're antipsychotics. If there was like a schizophrenia patient needing to get on in like a mood stabilizer, like, yeah, no. But, in terms of like first line medications, I can do all that. Anyone with step 3 and a full license can do anything, but I wouldn't go doing everything. Yeah, that's true. Technically, it's like the American College of like Physicians and Surgeons, right? So it's like, technically, if I was in a rural clinic in the middle of nowhere and like a farmer came in at 3 a.m. and needed surgery, like technically it's within my license legally to be able to do that. Would I ever do it? Absolutely fucking not. But technically you can. I mostly see kids on Abilify. Abilify is convenient because they have Abilify Maintena now, which is like an IM injection, and you only need to go in like once a month to get it. So especially for people who like don't take pills daily or remember to take it twice a day or whatever, Abilify injections is a very good one. Would you do Adderall? I did controlled substances in residency using our hospital's DEA, but now that I'm not doing a primary care clinic anymore and I only work as a hospitalist, I don't do controlled substances outside of the hospital. I do like pain medications. I prescribe opioids for like post-surgical patients that were discharging from the hospital, like 5 days of this or whatever. But I don't do like, I'm not going to refill your Adderall prescription or your Ritalin or whatever. Do you or Lev have opinions on intranasal ketamine? So intranasal ketamine, also known as esketamine, is super like end stage treatment resistant depression. You've literally tried everything. It also costs like $4,000 a dose or something, but according to Lev, it works. So definitely some good research on intranasal ketamine coming out to support treatment resistant depression. I don't think anybody that we treat personally will ever be able to afford it. Had to deliver a baby at 3 a.m. as a general practitioner one time in a rural hospital. Never again. Hell nah. Hell nah. Yeah, dude. Like I have not caught a baby since third year of med school. Like I have not done a delivery since third year of med school, and I'm going to keep it that way. I am not catching babies, dude. I remember when Maintena first came out, pharmacy cash price was like $2K an injection. Damn. All right, so she's 36 weeks gestation, first pregnancy, burning epigastric pain. I mean, it's probably GERD. Patient has fatigue and malaise, attributes it to pregnancy. She has no chronic medical conditions. She's had no surgeries. She takes a prenatal vitamin daily and acetaminophen for back pain. She does not use tobacco, alcohol, or illicit drugs. Father died of alcoholic cirrhosis, and her mother underwent a cholecystectomy for gallstone cholecystitis. All right, so I'm pretty sure this one's gonna be a trap answer because it's gonna tell you like, oh, you have to give the patient ursodiol or ursodeoxycholic acid, or you have to refer them for cholecystectomy after the pregnancy. But it's fine. It's fine. You can just chill. And you can just let them live with their gallbladder and the mild pruritus, and it's like cholelithiasis of pregnancy is the official diagnosis, I'm pretty sure. But let me read the rest of this question first. No, I was asking since he was prescribing things such as Lexapro, and I was wondering if he did Adderall at times as well. Yeah, I mean, like this was back in residency when I was working like a primary care clinic. So as a hospitalist, like I really don't prescribe medicines. I don't send medications to pharmacies unless it's like the patient is discharging under my care and I need to get them these medicines because like we started them in the hospital, right? So if they had surgery and I need to send them like Percocet, like yes, I will do that. Or if they had heart failure and we started like 3 new medicines in the hospital, like yes, I need to do that. So generally it's not really appropriate for me to just be like, oh, like you need a refill on your Adderall before you go. Like that's probably not going to look good to like a licensing board or whatever. So yeah, like I take Adderall. I go to a primary care doctor who takes care of me and writes my prescriptions because it's like, you know, you can't just prescribe controlled substances for yourself. May I interest you in a combo gallbladder plus C-section? No, thank you. Absolutely not. All right, blood pressure is 120/70. Pulse is 82. Exam reveals a non-tender gravid uterus appropriate for gestation. Yeah, so she's totally fine. Pedal edema during pregnancy is normal. So you wouldn't do maintenance meds, but send home medications. Yeah, I mean, maintenance meds, like things that they might randomly need. If the patient is like, hey, like, can you fill out my cholesterol medicine? I might need some extra. I mean, that's fine. But yeah, like I'm not going to be like, oh, if you didn't fill out your Ritalin, like you need to go back to your primary care doctor to do that. Like I'm not just going to send you Ritalin for the road. Adderall is DEA Schedule 2, 30-day fills, and you need a new prescription every 30 days. Yeah, so they actually changed this. Like when I was in residency, I could get my Adderall filled from like a televisit because I was able to, this was like a COVID era law where they relaxed the prescriptions from telehealth in order to allow people to have like more like success with getting medications from like virtual visits. But they walked that back a few years ago. So you can't prescribe controlled substances through telehealth without actually having physical follow-ups. So now, because I'm on a controlled substance, I have to go to the doctor's office every 3 months and basically just have like a check-in visit They do, actually last time they did my urine, just to make sure that it tested positive for amphetamines, to like make sure that I'm taking my medication properly. Because obviously, like if you're prescribed Adderall and then your, urine test shows up negative for Adderall, then people are gonna be like, are you diverting it or whatever, blah, blah, blah. So yeah, I just need to go in physically once a year. I mean, I don't know what the laws are in your state, but in my state, they took away that restriction, or they took away that leniency from COVID. So I can't get these medicines prescribed via televisits anymore. I have to physically go in every 3 months, which is annoying, but yeah. Okay, blah, 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 blah. Protein is blah, albumin is blah, Billy is blah, phosphatase is blah. So like, yes, it's cholelithiasis of pregnancy. It's not great, but you don't need to treat it. You don't need to rush to cut out the gallbladder. We can still have a healthy delivery and be fine. You're allowed to refill 90 days, 3 prescriptions for 30 days. Ooh. I miss getting 90-day stimulus. Yeah, I know. It is really annoying. Especially when I'm like a full-time doctor. There are times when I can't come in every 3 months. Like, it doesn't work with my schedule. They're like, why can't you come in? You need it to get your medicine. I'm like, I'm taking my medicine. I'm just busy. Does she have hepatitis? She has surface antibody, no surface antigen, no antibody IgM, so no acute IgA response, or no acute Hep A response. Total antibody is positive, so she had Hep A at one point, and she has no Hep C, so no HIV. Yeah, I'm just gonna say do nothing. Yeah, nice. I think we walked back the federal restriction on telehealth prescription recently. Yeah. In residency, I was able to just do it with telehealth visits, but I think this only happened like maybe 1 or 2 years ago. Like it's a pretty recent thing. Maybe even last year, honestly, like late 2025 or something. That's how it works in my state. You can technically get a 3-month supply on a class 2 drug if the doctor sends 3 separate prescriptions of 30 days. Yeah, something like that. I'm annoyed by the Hep B surface antibody positive levels with no antibodies. Ah! How are you going to give me a surface antibody and no envelope or no core? What do I do with these results? What kind of hepatitis panel is this? This sucks. How am I supposed to know to prescribe a booster? Defer to primary care. You can follow your vaccine schedule with your primary care doctor. All right, 30-year-old woman with ulcerative colitis with nonzalamine. Okay, so she is inflamed. Hospitalized for nausea, abdominal pain, diarrhea. She's had 8 to 10 bloody bowel movements every day for the past week with associated tenesmus, anorexia, and a 4.4-pound weight loss. So she is in a flare. No travel, antibiotic use, eating anything unusual. She does not use tobacco, alcohol, or illicit drugs. Temperature is 98.6, blood pressure is 110/70, pulse is 92, and respirations are 16. Examination shows a mildly distended abdomen. There is mild diffuse tenderness, but there's no involuntary guarding or rebound tenderness. Bowel sounds are present in all 4 quadrants. Stool is positive for occult blood. Okay, so I mean, she's obviously in a flare. They're probably going to ask us about management. I don't see any super big red flags here. A doctor can technically send a Schedule 2 prescription for a 3-month supply. It's only up to insurance. It'll be covered, or the pharmacy will consider filling that. Oh, that's true. So I had like a chronic pain patient, and the patient, like I documented very well that we were getting the patient follow-up in like a pain management clinic, but like the pain management clinic just didn't have enough availability to take them within a 3-month period. So I had to write the controlled substances myself up until the patient could be seen by the pain management clinic. And that's how I learned that Medicaid or Medicare, whatever insurance that was, only fills out from a hospitalist like up to like 750 morphine equivalents a month or something. Like they actually calculate your prescriptions based on the morphine equivalents and cap it on the morphine equivalent level. So obviously like a hospice or a palliative care doctor would be able to send more, but in a internal medicine like hospitalist capacity, the insurance like looks up what kind of doctor you are that's writing the prescription and then says like you can only prescribe this amount for this patient this month that will pay for, and then anything else like the insurance won't cover. So actually, yeah, you're right, it is also an insurance thing. Follow-up colorectal surgery outpatient. Thankful for this consult surgery. Oh my god, thank you for this interesting consult surgery to sign off now. All right, abdominal chest radiographs are unremarkable with no free air, no dilatation, so she's not impacted, she's not perforated. C. diff is negative, stool culture is sent. What is the most following appropriate next step for the management of this patient? So do you want to start them on infliximab? Do you want to do the colonoscopy now? Do you want to get a CT scan? Do you want to do antibiotics, or do you want to do glucocorticoids? So she is very much clearly in a flare, and I would like to treat the flare with steroids. Like, I'm not going to do antibiotics. CT scan, there's no reason to, because her x-ray is fine and she's stable. Colonoscopy, I mean, I don't know when her last colonoscopy was, but she's also, like, actively having 8 to 10 bloody bowel movements a day. And I'm not going to start infliximab now, because usually you also have to get their TB status beforehand. Donut of truth? Absolutely not. Okay, good. Good. It's a flare. It's a flare. When you have somebody in a flare, you give them the steroids, and then you give them the TNF inhibitor after if they don't respond. Also, you need to make sure that they don't have TB, because putting them on a TNF inhibitor can reveal underlying granulomatous disease. She would like to stop suffering ASAP. Exactly. I would like the patient to stop suffering ASAP. I do not want to put them in the donut of truth. We need Bill for a scope. Skin pathology. GI, I ain't going in there with that hostile bowel. You mean you don't want to perf that bowel for me? I'd go with glucocorticoids and then do colonoscopy with biopsy to diagnose gastrointestinal CMV related disease. CMV invasive disease related to UC, and then do IGRA for TB before it's TNF alpha. This is why you are the ID doctor. And this is why I am the internal medicine doctor. What is the normal range of total protein levels? I actually don't know off the top of my head. Good thing it's here. Is it here? Here. Total normal is 6.0 to 7.8 grams per deciliter. Albumin is 3.5 to 5.5. I don't know when you'd ever get a globulin level outside of maybe like a multiple myeloma workup. But this isn't like, I mean, protein levels like what we're talking about here is more just like for like proteins that exist in your blood, mostly to keep up things like your oncotic pressure by like existing to keep up the pressure gradient. This isn't like dietary like protein, like how much steak you're eating, because you're more concerned about like wasting diseases or losing protein through your kidneys, not really like, am I getting enough protein to like build muscle mass here? What's the donut of truth? The scan. Like putting a patient like a CT or an MRI and being like, donut of truth, tell me what's wrong with this patient. All right, 70-year-old woman presents to the emergency department because of anorexia, nausea, and diarrhea. So she doesn't want to eat because she's nauseous and she's pooping a lot. She's had symptoms for the past 3 days. She recently completed a course of antibiotics for bronchitis. Okay, so she had bronchitis, but she's not doing well, even though she already got treated. Medical problems include osteo, type 2 diabetes, hypertension, glaucoma, osteoarthritis. Her current medications. Oh wait, hang on. I'm getting messages again. Okay. What's fosinopril and what's the difference between regular lisinopril? I don't fucking know. This is a pharmacist question. It's an ACE inhibitor. It's an ACE inhibitor. I don't know. I don't think I've ever prescribed fosinopril. I don't even. This is like when like an Indian doctor like asks me like, did you try this medicine? And I'm like, I have no fucking clue what that is. Or like when someone in chat is like, oh, my mom is taking this. Do you know anything about this? I'm like, I know that we don't use it in America. No, this might be C. diff. Ooh, scary. Keyboard ASMR. This is a Hall Effects keyboard. It's a Keychron. What is it? Keychron HE K4 HE. Wait, what is it? K2 HE? K4. This is a Keychron K4HE. Yeah, I like it a lot. It's very fancy. Okay, so current meds are metformin, fosinapril, chlorthalidone, ibandronate, acetazolamide, and acetaminophen. Okay, so kidneys are on overdrive. Temp is fine, blood pressure is okay, pulse is 84, respiratory 16. On exam, she is uncomfortable. Abdomen's mildly tender. Test for stool for blood is positive. Oh no. All right. Complete blood count, so she's a little bit. She's got a white count. Sodium's fine, potassium's fine, chloride's fine. She's got losses. Creatinine's got a little bit of a bump, but she is on 2 diuretics, so could be normal, could be baseline, we don't really know. She's not oxygenating too well, but I think this is more of a metabolic acidosis. She was hospitalized recently for bronchitis. I think she has GI upset from the antibiotics, probably, or she finished antibiotics for bronchitis. She probably has GI upset from that, which is causing her diarrhea. Given her bicarb, her pH, and her PCO2, you know that this is going down, so this is acidosis. The bicarb and the PCO2 are following the same direction, so I think this is a metabolic acidosis. We calculate the urinary anion gap. It is 6436. Negative 36, so it's negative. So I mean, it's GI losses. I don't think the acetazolamide is doing this because that would cause an alkalosis. Type 4 RTA doesn't make sense because her potassium is fine. I don't think it's metformin, and I think this is just totally normal from the diarrhea. I have the LimoKey version of that keyboard. If you don't know, Keychron owns LimoKey. Yeah, I did not know. I'm like an entry-level keyboard enthusiast. Like I know like the difference between switches and stuff, but like I don't have anything like super custom. I understand like basic mods and stuff. Like I understand like sizes, switches, basic mods. That's pretty much it. Fosinapril is more expensive than lisinopril, and that's another reason why it's used less. That's why I don't know what it is. Fancy schmancy. I see a lot of hospitalists bringing their own keyboards to the hospital in the past few years. I do that. I have a 60% that I bring to the hospital. It's very nice. I was correct. Yeah. So you calculate the urinary anion gap, and it's negative, so it's normal response, and a non-renal cause, which is the diarrhea. Acetazolamide causes an acidosis. Oh yeah, no, not acidosis. It's a normal gap, like a non-anion gap metabolic acidosis. Chudayo, thank you for the raid. So my mnemonics are high anion gap is hard ass. No, high anion gap is mud piles, and then normal anion gap is hard ass. So Hagma is going to be methanoluremia, DKA, propylene glycol, iron isoniazid, lactic acidosis, ethylene glycol, and oh shit, what's the last one? Salicylates, maybe? And then hard ass is going to be hyperalimentation, Addison's disease, renal tubular acidosis, diarrhea, acetazolamide, spironolactone, and saline. So those are my mnemonics for the acidosis. You can remember bicarb is lost in poop and chlorine is lost in urine because the Argentinians say encarce un cloro for pee. Okay, let me just brush up on my Argentinian idioms, I guess. Do you have to know the pH bicarb, or is that all also in the resource section they give you? Bicarb level will probably be in your Chem 7 on the resource section, but in terms of acid-base disorders, you should already know acid-base disorders in general. Like, acid-base disorders you should know from med school. Actually, I don't think this is even like a board level question. This is a pretty simple like acid-base testing. Could this question be an RTA type 2? Well, it is technically an RTA type 2 because she's already on acetazolamide, right? And it's also an RTA type 1 because she's already on chlorthalidone, right? Man, that's so stupid. It's like RTA type 1 is the distal convoluted tubule, but RTA type 2 is the proximal convoluted tubule because they just discovered them in different orders. And then RTA type 4 is the collecting duct. Like, where's RTA type 3? Like, well, where's the loop? Salicylate toxicity is actually pretty bad because it forms a huge ball in the stomach, releasing salicylates forever. Salicylate toxicity is pretty bad too because it's a mixed acid-base disorder and the questions are impossible to solve. Skips type 3 to keep you on the toes. What exactly is like the main topic on this? Because I'm confused. So this is the internal medicine boards. So this is just a question bank that you would practice on after you complete everything. So there's like, you have the MCAT, which you take to get into med school. You have step 1 and step 2, which you take during med school. And then you have step 3, which you take during residency. But then at the end of internal medicine residency, you take your internal medicine boards, right? At the end of surgery residency, you take your surgery boards. So this is like the fourth exam, like at the end of all of your exams. So an exam after all exams, yeah. So I took this exam last year. I graduated residency last year, and then I took this last August. So I've been doing this question bank because one of my residents that works under me has it, and I was able to get his login info. But I thought it would be fun to just go through the questions. I did this last stream with another internal medicine doctor friend that I have, and this one is just me doing it solo. But I'm still doing fine. I think I'm like 11 for 11 still, so I still remember how to do this. A nondescript board prep question bank. This is not any specific question bank. Do not worry. Do not try to determine the identity of the question bank. I know it looks very familiar to a certain question bank that a lot of people know. Just don't worry about it. All right. 28-year-old woman comes to the office for consultation. She has a history of recurrent genital herpes, but no symptoms at present. She has 3 or 4 symptomatic episodes a year, but she has no other STIs, no other medical problems, takes no other medications. She has a new male sexual partner who is HSV seronegative. So she has a partner who does not have HSV, and she wants to decrease the risk of transmitting HSV to her partner. So you would do chronic suppressive antiviral therapy. So this would be with Valtrex, that you would just have them take every day. There's not another answer for this, right? It's like HIV, right? Like non-detectable means non-transmissible, right? So not just doing condoms, not just treating the outbreaks when it happens, but just giving them, the treatment, just like indefinitely. Valacyclovir. What about acyclovir? I mean, if we were in the hospital and it was an acute one, it would be acyclovir. So valacyclovir has that valine on it, which means it gets, popped off during the digestion. So it's an oral form that lasts longer. Do doctors have other types of tests like games or more interactive tests? I mean, so like if you're a surgeon, you have your surgery boards, which is like this, but then you also have like your oral boards. I think a lot of procedural based specialties also have more like oral boards, but internal medicine doesn't. I think emergency medicine does actually, but yeah, you also have to like go before like a group of doctors and like verbally talk them through a case, like how you would solve it and stuff. And you get like random quiz questions. It's literally just getting pimped. Like it's literally just getting pimped on like the thing. Like it's so stupid. But yeah, internal medicine, this one is just the board exam. We don't do oral boards for our specialty. I had a similar U-Globe question. U-Globe. Why is circumcision there? I don't know. 0% of people picked it. Why is it here? Meta-analysis has shown that male circumcision does not reduce HSV2 transmission. Duh. Psychiatry has an oral board. I remember since my dad had to take one. Oh. Alright. 35-year-old man is evaluated for pain and swelling. Did my voice just crack? What the fuck? Meta-analysis is sending me? Why the fuck? Right? Like, how did they sufficiently power a meta-analysis to see if circumcision reduced HSV2 transmission? 2, why did you need a meta-analysis to show that benefited anything at all? Snip, snip. All right, 35-year-old man is evaluated for pain and swelling behind his right foot that is exacerbated by walking. Chronic back pain occurs mostly during the morning and night. Pain improves during the day with exercise, but not with rest. He takes over-the-counter ibuprofen with significant back pain relief. Okay, so he's got swelling on the right foot exacerbated by walking, and he's got chronic back pain, but it's okay. It improves during the day, but it gets worse at night. He takes ibuprofen, which helps the back pain. He's got no fatigue, headaches, vision problems, abdominal complaints, no other medical problems. Mom has arthritis. Hemoglobin's 13, mean corpuscular volume's 88, CRP is a little elevated. Physical examination should focus on specifically which of the following. Fuck me. Okay, dude, what the fuck? Wait, I actually don't know where to start with this. So this arm span to height ratio, are they asking you to diagnose like Marfan's or something? Chest expansion? What do you mean chest expansion? Is that also like a Marfan's thing? Dix Hallpike is what you would use to diagnose BPPV, so I don't really know what that's doing there. Drop arm test is what you do to diagnose biceps tendinitis. I don't know what you're doing here either. Romberg test is like a antalgic gait diagnostic test. So I don't. Drop arm? Like empty can? Romberg? Like gaits? I don't even know what this question is asking. So he's got like pain and swelling behind his right foot. And it improves during the day, but it worsens with rest. Drop arm is supraspinatus. Oh, drop arm is supraspinatus. Job. Oh, I was thinking Job. Job is empty can, I think. Or I don't know. Don't ask me. This is such an ortho thing to ask. Like the biceps tendinopathy, rotator cuff tendinopathy. So it's like, oh my god, I did a morning report on shoulder problems for clinic one time. I think like the painful arc test combined with like the empty can test maybe has like a 90% sensitivity or specificity for like ruling in or out shoulder pathology, like rotator cuff pathology. Don't quote me on that. That's like the only thing I remember from shoulders. In my situation, my paw would draw a sample of their humors to look for an imbalance. Yeah, I might get this one wrong. I have no idea what it's asking me here. Pain and swelling behind right foot. Like, is that enthesis? Enthesis? And it gets worse with rest, but it's fine with exercise and when he's on his feet. Like, dude, I don't know. Where's the DO in the chat when you need one? Right? Oh my god. I'm gonna say... What the fuck is this? Dude, I don't even know. Is it ankylosing spondy? Is it chest expansion? Oh, fuck. Oh, it is ankylosing spondy. Okay, like that's why it gives you a CRP. And like maybe the mom talks about rheumatoid. Dude, I had no idea what the heck this question was asking. It does sound like this. We missed the trick by going allopathic. We gotta go back. All right, patient's presentation suggests ankylosing spondylitis. Ankylosing spondylitis usually presents in adults less than 40 with chronic low back pain due to sacroiliitis. Pain occurs during the day and night, tends to improve with exercise, but not with rest. Patients usually develop okay, so I got the enthesitis part. At the insertion site of tendons to the bone, limited spinal mobility or chest wall expansion. Oh, there we go. So it's the costovertebral rigidity that we are trying to get with the chest expansion part. So yes, A was looking at Marfan's, B was looking at BBVV, supraspinatus. Wait, who said that? Shout out to, oh fuck, my chat's not going up. Shout out to Zareth for remembering that drop arm is supraspinatus. Do these boards go towards your CTEs? My chronic traumatic encephalopathies? My continuing medical educational credits? No, these don't. The internal medicine boards does have a thing called like the longitudinal knowledge assessment, which you can do as a thing to get out of doing your boards every 5 years. Or you can also do the full board exam every 10 years. But I'm probably not going to do that one. It's hard to expand the chest when you have a spine of an Evangelion. Didn't we already have like a super kyphotic patient? Like chest expansion, lung disease one too? Ugh. Supraspinatus is empty can. Drop arm checks mostly all of this rotator cuff. What about speed? Dude, I used to know all of these, like drop arms, speeds test, Hawkins. Oh my god, Hawkins test. The lumbricals one with the index card. What the fuck? Dude, there's so much shit from like primary care, like outpatient medicine that I just don't remember. Gerber push off. Romberg test can detect neuropathy. Yeah, because it's a really like a spinal cord test too. All right. I'm just gonna skip that one because I knew it was ankylosing spondy. I just didn't get that from like the question stem at all. Aptly, oh, that's a good one. 63-year-old man comes to the office due to 2 months of back and neck pain. The patient has taken over-the-counter acetaminophen and ibuprofen, which provided some relief. However, the pain has recently begun to disturb his sleep. He has no weight loss, night sweats, or joint swelling, and no other medications. The patient's father had a prostate cancer at 65 and died from metastatic disease. Blood pressure is okay, pulse is okay, there's no peripheral lymphadenopathy, the liver span is 11 and the spleen is not palpable, no spinal deformity or percussion tenderness, there's no skin rashes, his prostate is mildly enlarged and rubbery. Well, that's probably just BPH. Complete blood count, hemoglobin is pretty low, MCV is okay, platelets are low, BUN is okay, creatinine could be a little high, but he's also been taking ibuprofen, calcium is fine, glucose, oh wait, calcium is high, I think? What is his calcium supposed to be? Calcium is 10.2 and he's at 11.7, so woo! Could be prostate cancer, could be multiple myeloma, could be a bunch of different things. PSA is fine. Radiographs of the lumbar spine show multiple lytic lesions and a compression factor of the L3 vertebra. Okay, so this is probably MM. Serum protein, agar gel, electrophoresis, and immunofixation do not reveal a monoclonal spike, but we gotta get the SPEP and the UPEP together. So this is just, you know, how to work out multiple myeloma. Multiple myeloma is a type of cancer that affects the B cells in the system where they just start shitting out a bunch of junk antibodies. And these antibodies just don't fight any specific viruses or make any specific, you know, immune or help you with any specific immune complex. But this junk just ends up depositing in your tissues. It ends up having to be peed out by your kidney, can cause kidney damage from there. And yeah, so even though that the serum protein didn't show a monoclonal spike, I think it's like if you only make multiple myeloma for, if you only make light chains or something, like they're all not going to show up on serum protein electrophoresis. So you also have to do the urine one because that's how you see the ones that are light and heavy chains. But don't quote me on that one. Okay, I got that part, but it's like, why do you do a SPEP and a UPEP? Like, I know you ordered the SPEP and the UPEP, but here, 20% of patients generate only light chains rather than full immunoglobulin. Light chains rarely increase total serum protein level, and they're not as easily detected on SPEP. Some of these patients have hypogammaglobulinemia, so you also have to do the UPEP to get the light chains. There we go. Oh, I'm surprised. Why would people want to pan scan him? Because this definitely sounds like MM, but I think it's just like they didn't realize that this is not enough, right? You still need to get the SPEP and the UPEP. If you've ever like tried to work up multiple myeloma in a hospitalization, first thing a nephrologist will tell you is to get a SPEP and a UPEP. So you do that first, and then you can do the pan scan to go look for the metastases. It's technically the right answer, but just these board questions are so anal with how they ask, like, this is the most appropriate next step. So if you have to get the most appropriate next step, then you got to go ahead and do the very next thing that they want. All the people going to sleep, have a good night. I hope you sleep well. Have a good week. How many questions did I put 40 questions in this vlog? Do I really want to do 40 questions? What do you guys want to do? Do you guys want to keep doing questions? 52-year-old man comes to the office due to difficulty falling asleep, frequent nighttime awakenings, and daytime fatigue. God, dude, why is it always sleep questions? Sometimes you do the SPEP and the UPEP needs to be sent to another lab because the hospital is poor. Oh no. But just remember what the Argentinians would say. Your eyes are kind of scary. Whoa, my bad. Most appropriate next step had better be the words on my tombstone. Felt, holy fuck. Dude, I hate these board questions because they're just so anal about those very specific things. Like the way that they want you to answer questions is just like either, well, I mean, it's multiple choice, which is like, okay, but it's just like either you're right or you're wrong and there's no in between. Like in real medicine, like you're getting good information with every test that you do. Right? So like, even if you order something that's not the most indicated or the next step, it still helps you rule out things and it still helps you like make a diagnosis, right? The problem is, on the actual tests, you don't get that. So if you just pick the wrong answer, even if you think you were right, because technically it has diagnostic value, the boards are just like, actually no, you're an idiot. You ordered a completely useless test. This patient just wasted their money. They just wasted their time talking to you. You're wrong. You're bad. You should feel bad. And you should never be a doctor. 500 cigarettes. Guy does sliding scale, caffeine, beer to sleep, and zins in between. What do you mean? That's just how every EM doctor operates. Do you not operate like that? I operate like that. Try EM boards, it's even worse. Ooh, I don't want to. Of course, the most next appropriate step in any situation is to perform hand hygiene. The answer is always hand hygiene. I don't care what the question is asking. The answer is always hand hygiene. Like, the Joint Commission secretly implants sleeper agents into the board committees, and they're like, hey, put a hand washing question in there. And they're just so terrified of them that they just do whatever they want. I think he needs more stimmies. Let's prescribe him Ritalin. Look at House MD. Most of every episode is him ordering the wrong tests. No, it's for the drama. It's for the drama. Can we add Vyvanse? I'm not gonna add Ritalin and Vyvanse. Guys, I really don't want to read this question. This is just like such a sleep polysomnography. Oh no, wait, depression screening. Dude, it's probably gonna be a depression screening. God damn it. It's probably gonna be a depression screening. I'm glad people want to be doctors. I would not survive any of these studies. I mean, it's something that you want to do because you're passionate about it, right? If you're not passionate about medicine, don't go into medicine. Like, I would say like we put ourselves through this so you don't have to, right? Like, we tell our patients, like, get 7 to 8 hours of uninterrupted sleep a night, like, eat healthy, you know, go exercise like at least 60 minutes a week. Like, we don't do any of that shit, right? Like, we work 80 hours a week in the hospital so that we can tell you to do the right things. I don't expect me to do these things because I'm trying to get you better. I'm not trying to get me better. I don't know if there's enough Siggy caps for depression. It's probably not even asking about that. It's probably just asking about, like, you have to assess him with Siggy caps first before you can even do that. Here, he recently went through a divorce and is under financial pressure to make childcare payments. Okay, so he's 52, right? Frequent nighttime awakenings, daytime fatigue. It takes him over an hour to fall asleep. He often awakens between 2 and 4. He struggles to stay awake during long staff meetings. No snoring, no shortness of breath, no chest pain. He recently went through a divorce and is under financial pressure to make childcare payments. History of hypertension, hypercholesterolemia. Family history is significant for CAD and emphysema. Patient smokes a pack of cigarettes a day. Drinks 2 or 3 cups of coffee every morning, energy drink in the afternoon, and a beer with dinner. Pulse, blood pressure, BMI, reindeer exam is normal, lab studies are fine, hematocrit's fine, leukocyte count is non-infectious, fasting plasma glucose is non-diabetic, and a TSH is 2.3. So, yes, I'm pretty sure he needs a sleep study, right? I'm not thinking that he needs a cardiac stress test. I'm not thinking that he has COPD. I'm not thinking that he has a REM sleep disorder. 100% he needs a sleep study. But because this is the boards and they're fucking asshats about the most appropriate next step in the management of this patient, when I literally just got off like a 3-minute rant about how stupid these questions are, they want you to assess his goddamn depression before you can actually work up the medical problems, because for some reason I'm a psychiatrist and they're telling you to stop focusing on medicine and make sure your patients are happy first. God damn it. So yeah, I don't think he has enough Siggy caps to actually diagnose depression. But because in his history, there is one throwaway line about going through a divorce and being under financial pressure to make childcare payments, you are remiss as an internal medicine doctor if you dare work up a medical problem before asking the patient, have you ever felt depressed? God damn it. Can fix financial issues. Stop smoking a pack a day. Okay, low key, I used to do that in residency too. Like, I would look up like prices of cigarettes with my patients and I would tell them, like, you're spending a lot of money a week on these cigarettes. Like, think about how much money you could save. Think about all like the good food you could eat. Think about like what other bills you could pay if you weren't paying for cigarettes. And that actually helped them a lot with motivation. But yeah, how on earth, Jesus Christ. Yeah. This is such a stupid question. Oh my god. The answer is polysomnography. I disagree with. Oh my god. Is this Lyme disease? It's definitely not Lyme disease. Okay. 24-year-old man comes to the office due to a non-pruritic painless rash over his upper and lower extremities. Vital signs are within normal limits. Skin exam shows scattered lesions shown in the image below. He has no oral or ocular mucosal erosions. Further elaboration of medical history in this patient is more likely to reveal which of the following. Okay, so this is really stupid, but I think it's not Lyme disease because target lesions do not appear in multiple groups like this and like the border around them. I think this is erythema margin. It's erythema multiforme, I think. Fuck. Is this a reactive? Is this a reactive? Like a gonococcal? Fuck. It's erythema multiforme. I don't know if it's gonna be recurrent painful perioral blisters or proceeding dysuria and purulent urethral discharge. When we were taught psych, we were told psychiatric conditions on the diagnosis of exclusion. Would you personally start on psych screenings or on medicine screenings? Okay, for the purpose of my job, I mean, I would not start on psych screenings, but for the purposes of boards, I have to start on psych screenings. Because if you work up a sleep disorder without first assessing for depression, then you're not doing the patient the correct service, because you could completely work up a sleep disorder and realize that they are totally fine and do not have a sleep disorder, and your problems could have been solved with Prozac like 4 weeks ago. So I don't know if it's ringworm. I think it's just a reactive. It's just a reactive erythema. It's A or C. No! Damn, this question was hard. This was 30%. This is 27%. Okay, definitely not B, because I knew it wasn't going to be actually. Dude, what the fuck? Herpes simplex? Fuck, I was so close. Dude, I was sitting in the right area. I like UTI, STI. Like, the diagnosis of erythema multiforme is based on clinical features. Skin biopsy can be helpful if the diagnosis is uncertain, but it's symptomatic. Although HSV infection is the most common cause of EM, antiviral therapy does not shorten disease duration. However, continuous prophylactic antiviral therapy is recommended for HSV-induced or idiopathic EM with frequent or severe recurrences. So I was thinking more like gonorrhea. Like, you know how the other question, I was thinking it could be like a gonococcal, like a gonococcal arthritis. Like, I was pretty sure this could have been the same thing for erythema multiforme, but I don't know why you would think this is a target lesion for Lyme disease. Like, that is such like a trap answer. Yeah, like this is what Lyme disease looks like. Like, this is what an actual target lesion looks like. Like, this is such a misnomer to call that one. Erythema multiforme is due to herpes sometimes. Man, herpes and gonorrhea probably just occupied the same space in my mind, which I feel like is not, you know, it's not like too crazy to say. Everyone was divided. Dude, 30%, 25%, 27%, 16%. That's crazy. Damn, that was super split. That was a hard one. Well, it wasn't even like hard. It's not like the question was long. It's just like, do people even like know what this is? But yeah, erythema multiforme due to herpes simplex. That is not something I would have gotten. I don't think I would have gotten that on boards either. Speaking of gonorrhea, have you seen the stuff coming out of Michigan lately? Why? Do they have like a... Do I want to look this up? Do they have like a super gonorrhea? I'm just going to Google up Michigan gonorrhea and we're going to see what happens. What do we got? What do we got? Oh, there's a chubby emu. Gonorrhea is evolving like never before. There are many instances of disseminated gonococcal infection. Ooh. Yikes. Yes. Yikes. All right. 60-year-old man is brought to the office due to difficulty walking. That being said, for all the herpes patients I see, I've only seen one erythema multiforme. Yeah, I would not make that link in my mind. I unless I got it on a board, unless like just now I got it wrong on a board question, I don't think I would have associated EM with herpes. Oh God, I know what you're talking about. Yeah, chubby emu. I Googled up chlamydia, or I Googled up gonorrhea, Michigan, and the first thing that popped up was a chubby emu video. All All right, 60-year-old man is brought to the office due to difficulty walking. He reports being weak and describes occasional brief episodes of intense back pain. Ooh. Brief episodes of intense back pain. Review of systems is negative for constitutional, pulmonary, cardiac, genitourinary, or other neurologic symptoms, including memory concerns. He has no known medical problems except for a remote history of treated pulmonary tuberculosis. He recently emigrated from China to the United States to live with his daughter after his wife died. Okay. 我演变成童话里你爱的那个天使张开双手 Lung exam is normal. Cardiac auscultation reveals an early diastolic murmur in the aortic area. Abdomen is soft and non-tender. Rectal exam shows an unremarkable prostate and normal rectal tone. Motor strength is normal. Bilateral lower extremity reflexes are diminished, and vibration and position sensation are decreased, and gait is steady and broad-based. Okay, so why are we constantly on the STI train? I mean, I'm concerned about syphilis here. So his daughter says that he is afraid of doctors and has not been evaluated in many years, and he's 60. I'm kind of worried about tertiary syphilis in this case. Grandpa from China might have super advanced neurosyphilis, because syphilis does go into your posterior column of your spinal cord. And kind of gives you those B12 deficiency symptoms. So diminished reflexes, vibration, proprioception, that's kind of subacute combined degeneration picture. Your Mandarin is so good. I mean, 我可以. 还有我的 my accent is so fucking bad because like one, I'm half Taiwanese, right? So like I don't pronounce shi, like I pronounce it like si. Right? So a lot of people think my accent's fucking terrible like that. Two, I can't read Chinese at all. The only Chinese characters that I know are the kanji from studying Japanese to like N4. And I just kind of reverse it in my brain and I try to pronounce it like how I think I would pronounce it. 好吧。第一天我跟你一样。All right. I think this is syphilis. I think this is syphilis. So his B12 is normal. They had to give you that because I was also thinking B12, right? Do you speak Hokkien as well? Chapa boy. my ama speaks with the rest of my, or I guess, damn, my ama died. I guess, yes, my mom does with her family on my mom's side, but I don't, and I don't think anyone else in my generation does. But I like remember trying to learn it from my ama. But the fact that I also call her my ama too means, you know, I'm Taiwanese. I'm Northwest Chinese, but I'm adopted, so my first language is English, but I'm learning Mandarin. I wish I'd tried to learn it more when I was a kid. But I think it was like my last name is Korean, because my dad is Korean, so my last name is Korean. And I grew up speaking Chinese with my mom, because I think it's like when you're a kid, you probably speak like your mom's language better. And I've been to Taiwan more than I've been to Korea, but my dad was like, your last name is Korean. You have a very common Korean last name. Like, you should know how to speak Korean. Like, your family expects you to speak Korean. Like, your friends expect you to speak Korean. Like, society expects you to speak Korean, whatever, blah, blah, blah. So, like, I went to Korean school when I was a kid. So, like, yeah, fine. But, like, I feel like Chinese is just more useful. And then when I graduated residency and I was, like, looking at jobs, like, when I was in, I was looking at, like, a couple ones in California, like, SoCal, LA area. And like half of them wanted you to be fluent in medical Mandarin. None of them wanted you to be fluent in Korean. I'm just saying. Good job, Dad. Good job. Syphilis, my worst enemy. Yeah, I'm gonna say it's syphilis. So this plus this and not following up with doctors. And the back pain is probably more from syphilis than it is going to be from the actual like a B12 deficiency or whatever he has. Gyro, thanks for the sub. I'm from Guangzhou, but I got adopted from people from Toisan. But the fact they didn't teach me either dialect and rip, I ended up learning Mandarin. Mandarin is just more helpful. It's, yeah, Spanish and Mandarin. 100% in America, Spanish and Mandarin gets you so many job offers. Like, I'm not even talking about in medicine, just like in general. Like, life advice, learn Spanish, learn Mandarin. You will get so far in life. Big plus on California. I know a tiny bit of Chinese. I'm more familiar with Nihongo, which I've studied myself for a few years now. No, it's lupus, not syphilis. Boo! It's never lupus. It's never lupus, except for the one U-globe question where it is lupus. All right. Do you do the immunoassay before a CSF test? This is tertiary. So first you need to get the ELISA, I think. What does it say here? Actually not sure. So the enzyme immunoassay is 100% sensitive. Wow, really? Okay. Yeah, so this one specifically was the immunoassay. It's not the RPR, because the RPR just fucking sucks, right? But this guy has tertiary syphilis, symptomatic tertiary syphilis, so you need to get the actual like high sensitivity test first, and then you would treat it. I don't even think that you need to do the immunoassay then. Or I don't even think that you need to do the RPR then. Is this my sign to learn Chinese rather than Korean after I spent a year learning Korean? Maybe. Mandarin speaking patient accused me of forgetting my ancestral language because I couldn't translate warfarin. Whoa, Fali. I don't what the fuck? How do you say warfarin? Hua Falin.
Hua Falin.
Hua Falin. What the fuck? Oh my god. Wait, what was this one? What's this one? Wait, where's the speaking icon? Oh, wait, I need to put on Google Translate now. What's how? Wait, there was like a super long name. No, so this one is Hua Falin, but there was like another one. Oh yeah, this one. What the fuck is this? Oh, Sha Shuling Hua Falin.
Sha Shuling Hua Falin.
This one is rat poison. So I think like last stream there was a question on warfarin, and JF was like, "Oh yeah, so we gave this guy rat poison," and I'm like, "Okay, wait, like warfarin was developed as a rat poison, but it doesn't mean that warfarin is a rat poison." So, rat poison is a super warfarin. You give rat poison to rats, and it's a super warfarin, so it inexorably inhibits their vitamin K, clotting factors, and they die because they bleed out. All right? There is a non-super warfarin, like a normal warfarin, that we use as a blood thinner, because it's not like completely irreversible, and it doesn't kill patients, it thins their blood. Enzyme immunoassay for syphilis is super sensitive. It's similar to MHATP and FTA-ABS, but it can remain positive forever even in treated patients. That's why you do a 2 to 3 step diagnosis. Oh, I don't know what the MHATP is. I know what the FTA-ABS is, but I know for a fact that the RPR is shit because there's like a bajillion things that'll also pop up positive on the RPR. I wonder if antibiotics are named different in Chinese or actually mimic the tone in English. That's a good question. I don't know. Like, the one thing that I learned about being a VTuber now is that, like, when I have so many other, like, international fans or, like non-English speaking fans, like, I just don't think about medicine in different languages at all. Like, it's so... Like, one, I'm an American, so obviously the world revolves around me, but it's like, I always thought that, like, everything in medicine would be taught in English. Like, we had a few international residents, obviously from, like, India and Pakistan. I mean, obviously, right? But, I mean, we had a few international residents from Poland and Germany and Austria, and they all learned medicine in English, too. Like, they did patient interviews and stuff in German, but they're, or Polish, but their tests and exams and stuff were all in English. So I always kind of just thought that, like, oh yeah, like, doesn't everybody like learn it in English? But I guess not. Some names in Chinese mimic the tones in English, like Anderson being an tu sheng or some sort. Probably. Hi Saiken, hello. Penicillin is what the hell is this? We learn in Russian. Also, probably biased because they probably went to like international medical schools. If the fact that they went to medical school in Europe and they applied for residency in America probably means that their school was more English friendly. Like the word for Spain is España, which sounds similar to Spain. Oh yeah, like how France is 法国. Which super elite Chinese gamer ball knowledge. you use 法国, like France, as part of an insult used for like the Chinese, like if you type in the F slur in like an online game but you don't change your keyboard language, you'll get like France, like 法国, and another character, and that basically ended up being its own slur in itself in like online Chinese games. Completely random facts. All right, it's the slur that's the same as the woodwind instrument. You know, the one that's like a bundle of sticks, or like how people in Great Britain would refer to a cigarette. Exactly that one. I'm here in Philippines. You learn English to kindergarten to college. Oh yeah, Philippines definitely. I would expect. I feel like Philippines, India, and Pakistan, they would probably learn English like before they even go into medicine. But I think maybe I was just biased on how I thought like the European residents that we had learned English in medicine, or learned medicine in English, because they probably went to schools that taught them in order to match in America, rather than schools that taught them in German to match in Germany. Survivorship bias. Yeah. Oh, so the French word for cigarettes. Yeah, the French word for cigarettes. Bassoon? Yeah, the other word for bassoon. It's nice to know that even in China they make fun of the French. All right. 60-year-old man comes to the office due to 6 months of exertional dyspnea and occasional headaches. He has had no chest pain, lightheadedness, or syncope. Patient injured his knee 8 months ago and required arthroscopic ligament repair. Due to restricted physical activity after surgery, he gained more weight. He has a history of GERD and seasonal allergies. Patient was a heavy smoker, but quit a year or two after being hospitalized with CAP. He drank 6 beers daily and occasionally more on weekends. Okay, that's a lot of beers. Beer. Have you guys listened to the Chinese Bill Nye song? Dude, why do we keep talking about Chinese shit? Like I was just with my family yesterday too, with like my mom's side of the family, so we're speaking Chinese there too. Dude, the Chinese Bill Nye song is so fucking funny. It's like 比尔是科学家，科学定义. And they go like beer. 是科学家. Dude, none of you know what the fuck I'm talking about. Why am I even laughing about that? Do you guys want to watch it real quick? Okay. Beer. 比尔是科学家。比尔是科学家。Beer. 比尔是科学家。
科学定律。
比尔是科学家。
惯性是物质的性质之一。
比尔是科学家。
倒数7秒，计时开始。
比尔是科学家。Dude, that's the greatest thing in the world. Oh my god, I'm fucking crying right now. I find it so fucking funny. This is what my sleep deprived mind sees. Yeah, why the fuck am I even doing board questions, guys? Why don't we just watch YouTube videos? Why am I doing board questions? Beer. 是科学家. You guys, the show is dubbed in Chinese. It is dubbed in Chinese. Let's watch Chinese Bill Nye. Dude, have you ever there's this really old anime called Chuka Ichiban, and it's like Super Cooking Boy in English. But for some reason, I have like a very ingrained childhood memory of watching the Mandarin dub of Super Cooking Boy. and I don't know why, but it's like the only reason that I wanted to eat mapo tofu for the first time. Long live the Mala Illusion. Hello, mother at Cookiebox. I wished happy birthday to daughter at Cookiebox earlier. You need to study for your boards. That's why I took this shit last year. This isn't even my question bank. I already passed this exam. I don't need to study for this. Did we come at the end? No. I watched the Chinese Bill Nye intro on stream for some reason. I just felt like watching the Chinese Bill Nye. The Cooking Master Boy show? Yeah. Chukai Ichiban. I just have a very strong memory of watching the Chinese dub of that. I don't know why. I don't know where. Maybe I was in Taiwan, but I just thought that was a Chinese show for the longest time, which I feel like you can't blame me for. But then like I saw like a clip like 20 years later. I was like, what the fuck? I watched this before. I watched this when I was like 2, but it just unlocked a memory. I'm here to be educated. All right, let's solve this problem. Let's solve this 60-year-old man that comes into the office with 6 months of exertional dyspnea and occasional headaches. MTF203 wants a random medical fact about brain. Okay. Did you know that you can localize a stroke based on its symptoms, and you actually don't need to shove the patient into the donut of truth in order to figure out what's going on with them? Or like if a patient has like a dominant temporal lobe, if the patient is aphasic, right, and you know they have aphasia, you know it's in the dominant temporal lobe, like you can say that before you shove the patient into the CT and try to figure out where it is. CT is gonna say no evidence of ischemic pathology, and you're like, oh, I gotta wait until the MRI comes back. I'm like, you know where the distribution is. Just remember your neuroanatomy. It's not that hard. Don't page neurology without head CT. Do they speak Taiwanese in Taiwan? Yes. Or most people. Okay. 1, most people speak English. 2, mostly people speak Mandarin. 3, like there is Taiwanese Hokkien that like my grandma and like my mom speak, but I don't speak it. Donut of truth. Donut of truth. Donut of truth. Fix it. Wait, this isn't a neuro question, is it? All right, it's not. Okay, so he injured his knee. He needed ligament repair. Due to restricted physical activity after surgery, he gained 10 to 15 pounds. He also has a history of GERD and seasonal allergies. Patient was a heavy smoker, but quit a year ago after being hospitalized with community-acquired pneumonia. He drinks 6 beers daily and occasionally more on the weekends. Blood pressure is 105 or 145 over 100. Pulse is 95. O2 sat is 93 on room air. BMI is 34. Cardiopulmonary auscultation reveals no abnormalities. Bill Nye tangent was long. Yeah, it was, right. Smooth liver edge palpated 2 centimeters below the right costal margins. Tip of the spleen is palpable, and there's no peripheral edema. Okay, so he's got, he's a big guy. His liver is big. His spleen is big. Oh, his hemoglobin is big. Okay. I think this question, yeah, and his erythropoietin is big. Okay, so this question wants you to know, do you know how to work up polycythemia? Does he have polycythemia vera, or does he actually have a myelodysplastic syndrome, or like a primary polycythemia from like a JAK2 mutation? It says he gained a lot of weight. All right, he is a heavy smoker. He drinks a lot of beer, right? This is actually not extremely alarming to me. I would not necessarily pursue a polycythemia vera myelodysplastic syndrome workup on this guy. I think he's just a bigger guy who has like oxygen reducing habits, and he's got a high amount of EPO coming out of his kidneys, and I think his body wants him to make more red blood cells. So I'm gonna say this one's not cancer. Some people say this is the cancer. Some people say his beer intake is big. Beer. What are the chances of complete recovery from a brainstem stroke? It depends where on the brainstem. It depends. I mean, like, you can't just do neuroprognosis without any sort of like imaging or testing. I do have a short on stroke. I do have a short on diagnosing brain death, right? So I mean, you can have anything from a TIA in the brainstem to straight up brain death from the brainstem. So, I mean, you can't really say from that. I just entered. I am very confused. Go for the girl answer, E. It is E. 100% it's E. There's no way this guy is cancer. Exactly. All right. The people were split. I would say in the real world, you would probably run a Jack 2 test anyway, but I'm pretty sure that this guy is just big and has some unhealthy habits, and you would just want to do his nocturnal oxygen saturation first. Because I think he just has a high oxygen demand, and his red blood cells are just producing more, or his body is producing more red blood cells in order to catch more oxygen. Why low platelets? Because he's got high EPO, so he's differentiating his myeloid lines into red blood cells more. No? Did I make that up? Maybe I made that up. The patients have had a splenomegaly with a smooth liver and thrombocytopenia likely represent alcohol-mediated end organ damage rather than signs of malignancy. All right, I definitely made that up. Damn, dude, I felt so confident about that. I was like, oh, he's producing more red blood cells, so on the myeloid lineage, he doesn't need to make as many platelets. Damn, that would have sounded cool if I got that right, though. Remember, drinking doesn't make you cool. And now you know. And knowing is half. Is this another mood question? I'm not gonna read the question. Wait, deadass? Okay, deadass. Like, I'm not reading the question right now. My eyes are closed. Like, I swear to fucking God, every single time the question asks you to assess for depression before doing the medical workup, the answer is always going to be assess for depression. And I don't know if that just means that internal medicine doctors are like being super shit with their depression screenings nowadays. But like, yes, I understand. You need to do those questionnaires and screen for depression before you do medical workups, because sometimes the psychiatric issue or like a medical issue is actually a psychiatric issue underneath. I understand that. I don't understand why every other fucking question on the board review is a psychiatric rule out question. Oh my God. I'm full. Dude, why was this one 93%? Wasn't the other like assess the patient's mood question like 40% or something? 74%? Why was this one like so much more obvious? Patient, husband, yep. Dude, it's literally like one line. They give you one throwaway line and you just have to remember like I gotta remember to be a good person here. Patient has dysuria, assess her mood. I'll watch this VOD tonight so I can sleep. My brain is very confused. I was randomly joining streams. I'll come back again. Love your stream. All right, thank you. Easy points. Dude, 93% of people got this right. That's crazy. Like, you always have to rule it out because it's so fucking easy to hand them a one-page questionnaire. Exactly. No, I'm not saying it's the wrong thing to do. You always should screen for depression. I'm just saying, why are there so many questions in the board review that involve screening depression first? Like, we know this, right? Unless they added so many questions in the board review because they found out doctors weren't actually screening for depression. But I feel like we know. What is the Montreal cognitive assessment? So the MOCA is like a neuro exam, MOCA. It basically gives you like a 12-step kind of questionnaire to fill out. It's like, follow these instructions, like what is happening in this scene, what is this animal, copy this figure, spell this, blah blah blah, and you just get like a very baseline like on how the thing is. Screen, that's what I'm watching this stream on. True. Slides PHQ. Yeah, I have the front desk slide a PHQ and then I do my fucking job. Is this a nursing question? Oh my God, what the fuck? All right, 66-year-old woman is hospitalized for the worst headache of her life. CT of the scan without contrast shows diffuse subarachnoid hemorrhage with interventricular extension and hydrocephalus. Because of the patient's deteriorating mental status and agitation, her trachea is cannulated and a CBC is placed. Which of the following is the most effective strategy to decrease the patient's risk for developing catheter-related... Oh my God. Okay, so this is... Okay, so I feel like triple lumens are more risky to get infected than single lumens. You do not routine catheter replacements. Prophylactic systemic antibiotics is not, because this is very stupid. You would not do this. IJ placement versus subclavian site would increase risk for infection. Oh, okay, so it's chlorhexidine best. Actually, honestly, this question wasn't that bad. But like, this is such a nursing level question. Like, if B, C, D, and E were like a little more like reasonable, like I'm not saying like they're right? Like obviously all of these are wrong, but if these were all reasonable answers and then chlorhexidine baths was one of them, and they asked me what of the following is the most effective strategy, I probably would not have gotten that right. Because like I know we do charge baths, obviously, like CHG baths, obviously, but like most effective, like I would not say that that is more effective than any other strategy to decrease risk for developing CLABSI, right? Like that's crazy. Like they have questions like this. Obviously, B, C, D, and E are like aggressively wrong. I don't know why people picked any of these, but like, damn, like that is a very hard, like it's probably a very extremely easy nursing level question, but that's actually a very hard doctor level question, you know? Yeah. Did you check her mood? Did you check her mood? D, inflate my procedure numbers. You're PGY 1. You haven't placed 30 central lines already? I'm so glad that 0% prescribed antibiotics. Dude, infection control would probably be like, what the fuck is wrong with you? The infectious disease, the antibiotic stewardship mafia would knock on your door at 2 in the morning and be like, Dr. Saiken, what the fuck do you think you're doing here? Oh my god. Oh no. Dude, what are these questions? Oh my god, it's like, can I just get like a normal medical question? Did you check they were depressed first? I don't know. Fuck. This is kind of like, can I just get like a normal medical question where we do medicine? Why am I helping a guy not drive? Dude, this is such a common type of question too, where they give you like a shit ton. They give you like an entire novel, and then they give you like a very simple question. That's not a joke, by the way. oh fuck. Oh fuck. Oh fuck. Oh fuck. Reading. Hey, can you guys read this question for me and then just give me a TLDR? Because I really don't feel like reading all of this. What do I tell this guy regarding his ability to drive? Can you read? Because I don't. General exam is unchanged. Like, what are we doing here? What am I doing here? Surprise, you're doing a DO course. Oh my god. I have to learn my OMM. I have to manipulate his eyes. How would you react if you found out a farmer brought himself out to the hospital voluntarily? What the fuck? Get this man a hospital bed immediately. Whatever he has is not good. All right. The answer is either going to be he can totally drive or he should stop drive. Because like 100%, these are the only two answers, right? Like these are the only two answers that we can give. So it's he can drive or he cannot drive. Okay? And I feel like the question is going to try to give you a bunch of red flags and tell you that like he's super at risk for driving, but he's actually totally fine for driving. Are you confident in that? Because I'm confident in that. I'm just going to say B, and I'm just going to say fuck off. All right, good. Okay. Dude, these questions are so stupid, because it's like, only one answer can be correct, which means the other answer is wrong. So it's like, god damn it. All right, 80-year-old man follow-up visit. Prior to entering the room, patient's daughter wants you to dissuade the patient. Oh, yeah. Anytime the family member tells you to do something, it's not the right answer. She relates she doesn't have any specific reason other than his advancing age. He's becoming a little forgetful, and she worries about him driving. Okay. Just read the second to last paragraph. BP is 136/84. Pulse is 72. General exam is unchanged. Head and neck mobility are fine. Gait is normal. Tug test is 14 seconds. His MMSE is 26/. Okay, so he's only went down one. Patient lives independently, performs all of his own activities of daily living, including his own shopping. He drives approximately 3 to 5 times a week for shopping, restaurants, and entertainment. He's only had one minor fender bender when he backed into a short stationary garage that he cannot see a year ago. He's not had any traffic violations, denies having any close calls while driving. He's never gotten lost while driving. He has cataracts, but his recent eye exam showed a corrected vision of 20/40 in both eyes and good vision. The last driver's license renewal was 12 months ago. He realized he feels comfortable. Dude, he's totally fine. He's totally fine. What the fuck? It is primary care, right? Obviously, as a hospitalist, I'm like, why the fuck am I bothering to do this? But technically, internal medicine boards doesn't care if you're a hospitalist or a primary care doctor, right? Like, I still have all the qualifications to be a primary care doctor. I would never fucking do it, but I still have to be able to answer office-based medical questions, just like how JF would have to do like hospital-based medical questions. I just didn't feel like reading the whole question, okay, guys? I just didn't I just didn't feel like it. All right. Which of the I'm not. It's another one. I'm just not gonna read the question again. Fuck it, dude. What? It's a COPD patient. Which of the following do inhaled corticosteroids increase? Pneumonia. Ooh. Ooh. Shit. Actually, wait. Which of the following do inhaled corticosteroids increase? Cardiovascular mortality or pneumonia incidence? B question mark? Like, I feel like it was E. Because I feel like I remember learning that. But I feel like cardiovascular mortality is also a legitimate thing. The rest of this does not matter. This entire thing does not matter. Like, this whole vignette is so pointless. If you were on the exam at this point and you wasted time reading that vignette, like, you would literally just kick yourself for wasting a minute. Which of the following do inhaled corticosteroids? Oh, inhaled corticosteroids. Okay. Yeah. Not systemic corticosteroids. Definitely inhaled corticosteroids because it's like, you can get like fresh and shit. Yeah, inhaled. See, that was a thing where it's probably like, you got to read the question because it was like, I was thinking steroids. I'm like, actually, wait, but yeah, 9% of people said it increases mortality, which for steroids, I would probably believe more, but inhaled corticosteroids, 100% it would be that. Is this a real question? Can this be a real question? Okay, guys, it's a real question. Okay. Oh, fuck, is this oncology? Fuck, okay. You always read the answers first. That is a good tip. Like, I'm reading the whole question because we're doing this on stream together, right? But usually, like, my actual test taking strategy is I read the final question. So it's like, which of the following, or what is the most, or like, what is the next step, blah, blah, blah. And then I read the answer choices. And then I work backwards and I read the question from the start. So if I was doing this like it was an actual question, I would be like, what's the most appropriate next step in the management of this patient? So I'd be like, oh, okay, it's a diagnosis question. So the answers are bronch with BAL, CT scan, NSAID and follow-up, oral antibiotic, clinical follow-up. So I'm thinking, okay, do they want me to think about pulm? Do they want me to think about cancer? Do they want me to think about primary care follow-up? Do they want me to think about like doing a VATS or something? This is how I read the actual paragraph now, because I'm trying to find clues that support, you know, oh, this deserves more of a pulm workup. This deserves more of an onc workup, etc. Bored guy fuming watching you guess the answers from the answers. Okay, no, this one I'm doing for real. Okay, like this one is how I would actually like do a question. Okay, so you go to the question, you read the answers, you think about what the possible topics of the things are, and then you go backwards and you go for. Do we actually have to know lights criteria for this BS? I don't think. So total protein is less than serum, pH is lower than serum, and LDH is lower. I mean, I think this is just exudative. This is exudative. All right. 42-year-old woman comes to the ED due to shortness of breath. Approximately 2 weeks ago, she has shortness of breath on exertion that became progressively worse. She reports mild chest pain with deep inspiration. She has had no weight loss, fever, cough, or sputum production. Medical history includes diet-controlled type 2 diabetes and locally advanced infiltrating ductal carcinoma of the left breast, which she already underwent neoadjuvant chemo and surgical resection and radiation 2 years ago. Okay, so she's already had cancer at one point. All right. Patient is a lifetime non-smoker and has no significant secondhand tobacco exposure. She lives with her family and works as a teacher. So temperature is 99.7, blood pressure is 122/78, pulse is 92, respirations are 20, oxygen sats are 92% on ambient air. Physical examination shows moist mucous membranes with no JVD or lymphadenopathy. Heart rate is regular with no murmurs or gallops. Auscultation reveals decreased breath sounds over the right lower lung with dullness to percussion, which you can see on the x-ray. Remainder of the exam is normal. Upright chest x-ray reveals the following. Doc, what's your opinion on street medics, non-EMS para-protest medics? Oh, well, I mean, obviously, like, EMT and, like, paramedic stuff are, like, a lot different from we do, right? It's not about diagnosing, it's about stabilizing, right? So, I mean, they're indispensable, right? I mean, I'm not going to get a single patient in the hospital if they all die in the field before the EMT can bring them here, right? So obviously, like, respect to them and everything that they do to like stabilize patients, right? Yeah, street medics or something, like random guys bringing people in, like sometimes they can do more harm than good, right? But I mean, we would not have patients in the ER if not for like ambulance drivers or people to drop them off, right? So I don't blame EMS for getting things wrong sometimes, right? Like if EMS gives a patient with heart failure fluids, right? Like I'm gonna be like, oh fuck, EMS like gave them like a 500 bolus, but like, I mean, I don't expect them to know the full history or like anything. Like I don't expect them to be able to like do a complete workup like this or like know all these things. So I mean, it's not necessarily their fault if they do something wrong. It's just given the resources that they have and the type of medicine that they do, they are there to keep the patient alive from discovery to transfer, right? So that's what they're responsible for. This is a really shitty x-ray, but you can basically see that she has no costophrenic angle on her right hand side. So over here you can see this little dip over by the stomach where you can see that you are able to visualize this space where the lung is having enough volume to expand and have air over here. On this side, you have a big ass pleural effusion over here that's completely whiting that out. So obviously she has an exudative pleural effusion. And I think the question is asking you, is this going to be like a pulm problem? Is this a parapneumonic effusion? Is this going to be a metastasis? So the cytology says negative for malignant cells, but I do not think that has much value here because the fact that she already had cancer with radiation, resection and radiation 2 years ago, like I'm calling this a malignant effusion until otherwise. So oral antibiotic clinical follow-up, like not appropriate. She has an effusion. It's not parapneumonic. Non-steroidal anti-inflammatory agent and clinical follow-up, like shortness of, like what the fuck, what is that going to do? What? Bronchoscopy with BAL, I mean, you're not going to get anything about the effusion from the lavage, right? So it's like, I'm not going to say that these are good answers, but does she need a pleural biopsy? Probably not, because we already have a potential source. So yeah, okay. The 27% of people already did this here. Thoracoscopic pleural biopsy can be useful in diagnosing suspected malignant pleural effusion or pleural effusion of unknown etiology. However, CT scan should be performed first to guide the location of biopsy. Okay, so I was thinking more looking for like a Metz angle, but yes. Okay. In this case, it will allow evaluation for metastasis or areas of pleural thickening that may be amenable to diagnostic tissue biopsy. So the CT is actually pulling double duty here because one, it lets you show any Mets, and then two, it also lets you get a target for pleural biopsy. So that's obviously more correct than just doing the biopsy blind. Any department would be like, what the fuck do you want me to do based off of an x-ray? The big Hazu raid. Thank you. The next step would be to clear the effusion, no? So yes, draining it could help, but also you would want to see a pocket where you could drain it, and you would also want to evaluate for lesions, which is why you would want to get the CT first. That's all I get? What do you want? Hi, my name is Hazumi. I'm a Lioness Knight VTuber and I'm going to protect you forever. We are rating Saiken MD, who is a Dr. VTuber, internal medicine doctor in real life, doing board review. Please go watch my newest short. I spent a lot of effort on it, and I would really appreciate it if you guys watched it. Thank you. I thought that was pretty good. You guys think that was good? I thought that was pretty good. I hate you so much. Why? It's a good short. It's a very high quality cover. What's wrong with it? What the heck? I think it was exactly. I think it was accurate too. Hey, this question's about anal. You'll like this. All right. 33-year-old man comes to the office due to persistent anal pain. 2 months ago, the patient experienced severe anal pain associated with bowel movements. Evaluation revealed an anal fissure and external hemorrhoids for which he was treated with stool softeners and topical nitroglycerin. You gotta read Haz's response in your Haz impression too. This needs a mood check. Guys, can this patient drive? He has anal fissures. Can he drive? All right, so he had stool softeners, topical nitroglycerin. His symptoms have persisted despite adherence to medical therapy and high fiber diet. So he's still having anal fissures. He's still having anal pain. And every time he has a bowel movement, so anytime he's pooping, like the stool is hard and it's passing over the fissures and probably the hemorrhoids too, and it's granting him a lot of pain. I would not recommend driving with anal fissures. No, it's because it's like we had 2 questions ago. We keep having to do like mood checks or like driving checks or whatever. So that's why I was like, wait, can this guy drive? I think you need to check if he's depressed. Yeah, he's depressed because he has anal fissures and it's painful as hell, and that's why he can't do anything. His symptoms have persisted despite adherence with medical therapy and high fiber diet. He reports no history of anal trauma or anal intercourse. Vital signs are within normal limits. Rectal exam is painful, reveals a posterior midline anal fissure, large skin tag, and external hemorrhoids with no thrombosis. The remainder of the physical exam shows no abnormalities. Blood counts and serum chemistry are fine. Which of the following is the most appropriate next step in the management of this patient's disorder? So he reports no history of anal trauma, no anal intercourse. So, syphilis, HPV leading to malignancy is less likely. Is it clearly anxiety? Yeah. I'm going to sleep before the sleep medicine agents catch me. Yo, just make sure you don't send the antibiotic stewardship mafia my way. Rubber band ligation wouldn't do anything for externals. So actually, I think this is Crohn's, right? He's 33, right? So he's a young guy. He's the right age. And the biggest thing was with Crohn's, as opposed to the other inflammatory bowel disease, ulcerative colitis. Ulcerative colitis only affects the mucosal layer of the intestines, whereas Crohn's affects transmurally, which means it affects the entire wall. And these big knife-like fissure lesions, they happen from the mucosa all the way to the basement membrane. So when you get anal tears and anal fissures, these are actually just Crohn's lesions that are extending transmurally across the whole thing. So I'm gonna say we have to rule out Crohn's because, I have nothing to suspect that it might be HPV or it might be, internal hemorrhoids or anything. So yeah. Patients with non-healing atypical anal fissures, colonoscopy, and small bowel imaging to rule out Crohn's disease. Yeah. So like he's been on all the correct therapy, but he keeps getting recurrent external hemorrhoids and anal fissures. You probably want to make sure he doesn't have a GI pathology there too, right? Like maybe, fine. Like maybe he has like HPV or something. Maybe he does have an anal malignancy. It's just unlikely, right? So like we're not saying that these things are completely out of the option, out of the scenario, but it's like most appropriate next step, right? In real life, you're probably not wrong ordering all of these things, not just to cover your bases, but to really rule out different conditions on the differential. But that's the problem. Like on the test, you don't practice medicine like you practice in real life. And the test only asks you what the most appropriate next step is. So you have to pick what's the most immediate thing that's going to give you the most information for this. I love how the internet treats 40-year-olds as withering people, but doctors go, oh yeah, he's pretty young. Well, he's 40. He's older than me. Whoa, that's unk right there. Don't come at me with that. I mean, oh shit, wait. I mean 40's pretty young. I mean, it's not. He's not old at all, dude. I need a mood check. I need a mood check. All right. Oh god, didn't we just talk about how I don't want to do eyes? I don't want to do eyes, man. All right, call optho, right? Yeah. 22-year-old woman comes to the urgent care clinic with a painful, gritty sensation in her right eye, swelling, and photophobia for the past 2 days. She's been studying for college exams and initially attributed her symptoms to fatigue. The patient wears contact lenses for myopia. Right? I mean, like you think it'd be like corneal abrasion or whatever. Like you can't contact lenses. You're worried about pseudomonas, so you have to. Yeah. I don't have a good reason for that. It's just anytime someone comes in with contact lenses, you have to treat it like it's pseudomonas, and you have to make sure that you moxifloxy that, because if you don't moxifloxy it, erythromycin's not going to take care of it. Moxifloxy. Oh, actually, it's not moxifloxy. It's gadafloxacin. What the fuck is gadafloxacin? What do you mean there's more fluoroquinolones other than levo? What the fuck is gadafloxacin? Gadafloxacin? Wait, can I get a price check on gadafloxacin? Price check on gadafloxacin and IL-3? It's a 4th generation fluoroquinolone used for eye infections. Oh, it literally, oh, it's okay. It's literally just a eye fluoroquinolone, yeah. But yeah, broad spectrum topical antibiotics with Pseudomonas coverage. So basically it was just like contact lens, like acute bacterial keratitis, contact lens, fluoroquinolone. Do we need to check you for depression? You need to check me for gadafloxacin. You know what's rare or really bad, and even the doctor doesn't know what the fuck it is and has to Google it? Yeah. Moxifloxacin is not active against Pseudomonas, with love from the stewardship mafia. Man, I thought you went to bed. Can I use Levaquin? Would Levaquin been like a better answer? Like, what the fuck is gadafloxacin? I don't even know what gadafloxacin is active against. Gadafloxacin was not mentioned once in pharmacy school for me outside of it being on the top 200 list. Oh my god. Ironically, pharmacists are technically Googling shit all the time. Technically, I'm Googling shit all the time too. Alright, 44-year-old man with HIV infection is evaluated for persistent fevers, progressive generalized fatigue, poor appetite, and marked weight loss over the last 2 months. He has no chest pain or shortness of breath. He's been non-compliant with antiretroviral therapy, and his last CD4 count 6 months ago was 90. Okay, so not terrible. Not great, but not terrible. His temperature is 38.3, 101, okay. BP is 91/53, pulse is 105, and respirations are 21. Exam is pale conjunctiva, dry mucous membranes. Okay, so this guy is not doing too good. Hemoglobin 7.8, platelets are 70. He's got like no leukocytes. CT scan is, oh god, lucencies in the skeleton and bulky mediastinal and abdominal lymphadenopathy. Bone marrow biopsy in this patient would most likely show which of the following. Oh man, okay, so okay, so I mean, he has acute HIV. He's non-compliant with antiretroviral therapy, so I mean, he's like super immunocompromised. This is lucencies in the skeleton is probably a trap answer for multiple myeloma. Just off of nothing else, bulky mediastinal and abdominal lymphadenopathy is making me think non-Hodgkin's. Kaposi's, I mean, I don't see any sarcoma signs. Fungal infection, I mean, I don't know. Kaposi's from the HIV. What is it, like HHV 6 or HHV 8 or whatever? Kaposi's a red herring? Is the bulky mediastinal abdominal lymphadenopathy a red herring? I don't know. Dude, he's got so much going on with him. So fevers, fatigue, appetite, weight loss. Ugh. Like, I would say all of it is acute HIV until it got to the bulky mediastinal and abdominal lymphadenopathy. It's just, it's screaming at me non-Hodgkin's, but like, I don't have a better answer. Lucencies in the skeleton, I mean... Of course ID appears when I'm going to bed. Go to bed! How are you vibing with that adenopathy? Like, the adenopathy is giving lymphoma. Like, is it wrong for a lymphadenopathy to give a lymphoma? Like, it's giving. Burkitt's lymphoma could be. Like, shortness of breath is abbreviated son of a bitch. Yeah. God, this short of breath. I diagnosed him with doing bad. Aplastic anemia. Is it a pure red? No, it's not a pure red cell failure. I don't know, actually. But, like, hemoglobin is 7.8. Like, is that aplastic? What if he just has, like, iron deficiency, right? Because, like, you can blame the leukocytes. Actually, you can blame the plate. Oh, actually, wait, it's Damn, I actually don't know. Do I go with my gut? I want to go with my gut. It might be wrong, though. Oh, shit! Okay, Jesus. Dude, what? This was rough. This was rough. Okay, hang on. There's no peripheral blood. You can't say if it's aplastic, though. Yeah, exactly. Because I was like, he just has, like, no leukocytes because he has a CD4 count of, like, 90, right? Like, if he's got active HIV, I'm not trusting anything from that differential. Pancytopenia is due to HIV. True. All All right, with this, I need to read the whole thing. Patients poorly controlled HIV status, marked body cavity lymphadenopathy, and bone lucency. The most likely underlying cause is non-Hodgkin's. Around 4% of HIV patients have lymphoma at the time of diagnosis, with the same percentage developing lymphoma during their disease course. Factors that contribute to the incidence include direct effects of HIV, immunosuppressive state, co-infection with other oncogenic viruses like Epstein-Barr, and environmental oncogenic stimuli. Heart prevents severe immunosuppression, which in turn helps decrease the incidence of non-Hodgkin's. Patients with non-Hodgkin's tend to present with B symptoms. Yeah, so that's where I was getting it, right? So it's like the bulky lymphadenopathy with the B symptoms. But then it was like complicated with the HIV. So I was like, I don't know. But this is what Adam Elik was saying, right? So diffuse large cell, non-Hodgkin's, and Burkitt lymphoma are the most common related AIDS lymphomas. My lizard Anki brain went HIV to Kaposi. Yeah, but like it's a sarcoma. You would have skin lesions, right? Like you wouldn't just have like the lymphadenopathy, right? You would have like the black Kaposi stuff going on, like because it's a sarcoma. It's a mesodermal, mesenchymal, origin. Like you wouldn't just have like lymph node stuff going on. We recently had a young man with Burkitt's with the main bulky mass in the neck. Oof. The DLC eliminated A. All right. Okay, it's almost 12:30. Let's do like, oh god, what the fuck is this? All right, let's do like 3 more. That'll be 30 questions. That's pretty good. I feel like 3 more is a lot, but I feel like I want to leave it at like a nice even number. Dude, I hate these questions so much. Fuck. It's like, does the first one go up or down? Does the second one go up or down? Does the third one go up or down? Does the fourth one go up or down? Board questions are not fun alone. Yeah, I can't believe I used to stream this. Like when I was actually like studying for boards, when I was studying for step 3, I think I streamed it. I just like it's a lot more fun when I do it with JF. Honestly, I should do this with Bree. I should just get Bree here and make her do board questions. It's multiple choice, right? She has a 1 in 5 chance of getting them correct. Obstructive, restrictive, mixed. Yay. Yay. Oh god. 34-year-old woman comes to the physician's office due to worsening shortness of breath over the last 6 months. She can no longer walk a block or climb a flight of stairs without stopping to catch her breath. Okay, so she's 34, right? I think this is like pulmonary arterial hypertension, maybe, right? Idiopathic, like PAH in a young woman. That's a thing. Patient's occasionally lightheaded when trying to exert herself. Albuterol inhaler prescribed 3 months ago provided little relief. Yeah, because it's not asthma. She's not used tobacco. Bree, this guy has anal lesions. Bree, does he have a colonic fistula? Ah, shit, I take step 3 student. Oh, do a step. This is basically a step 3 question, dude. This isn't like an ABIM question. This is step 3. You can do this one. All right. Echocardiogram shows a moderate right ventricular dilation and hypokinesis with increased flow velocities through the tricuspid valve. All right, so it's I'm pretty sure it's PAH, right? Which one of these is PAH? I think it's this one. I feel like PAH has normal PFTs. So all of these are like different pulmonary function tests. Like your FEV1 is like your forced expiratory vital capacity in like 1 second. Like how much can you go like, and then your FVC is like your forced vital capacity. So it's like how much can you go like, and then the ratio of your FEV1 FVC when you divide those, depending on which one is worse than the other. Like low is going to be like COPD, high is going to be like a restrictive disease, and then DLCO is the diffusing capacity for carbon monoxide, which you would get worse in like different restrictive diseases. But I think this patient is normal because she has a totally different disease, which actually has to do more with blood flow, because she's got right ventricular dilation and hypokinesis of the flow velocities across the tricuspid valve. So her right side of the heart is working harder because it has more to overcome in the pulmonary artery, which is leading to her symptoms. So it has nothing to do with COPD or... Oh, fuck! Wait, what's the difference? Oh. So one's normal and one's not. So, okay, this has nothing to do with obstructive or restrictive. This is just a normal one, but like her DLCO is supposed to be 50 instead of 81. Whatever. It is... Okay, the diagnosis is right. It's pulmonary arterial hypertension. Is DLCO low in PAH? I guess. I thought it would be normal. Yeah, DLCO is low in pulmonary. Shit, I should have listened to the chat. Okay, wait, why is it low though? Pulmonary hypertension from thromboembolic disease, secondary to reduction area. Both mechanisms lead to VQ mismatch, which is evidenced by the decline in the diffusing lung capacity of carbon. Oh. So it's a VQ mismatch. So if you're shunting, then you technically have lower diffusing capacity. This is particularly true of symptomatic PAH. DLCO may be normal in early stage asymptomatic PAH. Yeah, okay. I was thinking like there's actually nothing wrong with the actual lung tissue itself. So that's why I thought it would be a normal DLCO. But I guess if it's a shunt and it's creating a ventilation perfusion mismatch, then the DLCO is low by definition. Huh. Okay. Sure. Fuck it. Dude, so why does this one say this DLCO is decreased in normal COPD, but can also be normal in early COPD? But this one doesn't have the same marker that says decreased, but then normal in early PAH. Huh? I feel like this one could have been right. Whatever. Fresh into MS2 here. Is this what awaits me? Honestly, this was like a step 2 level question. So as an MS2, yes, this probably does. My first guess was cardiac. Well, I mean, she's young. She's young. She's a non-smoker. She, big red flags just for PAH right there. Cardiac from this is not necessarily cardiac. This is her right side of the heart. So this is all of the blood flow that's going into the pulmonary vasculature, right? It's not a heart problem in the fact that her heart isn't pumping forward and getting blood into the rest of her body. It's her heart isn't pumping forward because it's not overcoming the resistance correctly on the right side of the heart going into the pulmonary artery. We should have known if we had performed a mood check. Fuck me. Fuck me. All right. Can I redeem myself? All right, let's do 2 more. All right, we can do this. Mood check, posture check, hydration check. I gotta walk my dog after this. Okay. 80-year-old woman comes to the physician accompanied by her daughter, who is concerned because her mother no longer participates in group activities. Patient has lived in... Oh, come on. Fuck. No! Why? Why? The mood check, driving ability check, home geriatric assessment. 100%. I don't care. Crazy how I have a streak on here. Patient has lived in an apartment with an Okay, well, she lives in an assisted living facility, so I don't think it's home geriatric assessment. I don't think it's home geriatric assessment because she literally lives in like the perfect like assisted living facility. All right. She no longer attends communal movie nights or bingo games, eats all of her meals in her apartment, oh my God. She feels well and has not been depressed or fatigued. She says she sometimes forgets stuff, but is still able to function independently. Hello, she just gave like 4 things she doesn't do anymore. She's not fallen in the past year. She has dementia. Mood check. Patient has osteoporosis, hypertension, osteoarthritis, blah blah blah, medical problems, blah blah blah, proper noun, place name, blah blah blah. She's alert, attentive, pleasant, well dressed, well groomed. Chest abdominal exam are unremarkable. There's no muscle weakness. DTRs are normal. Gait is steady. 27 out of 30 on the MMS. Oh, wait. Geriatric depression scale screening test is negative. Wait, guys, they already screened her for depression. Oh my God, they already did a mood check. Oh my God, they already did the mood check. What the fuck? Did he just quote the Lego movie? Yes. Wait, what do you mean? What do you mean? I get to do medicine? I get to do medicine? Okay. Okay, so she lives at an ALF. She lives at an ALF, so I'm not really worried about doing a geriatric assessment. And she's already not depressed. So we don't have to do a mood check. They did the mood check, guys. Don't worry. I thought you were going to bed. Good afternoon from work. Thanks for streaming these. So interesting to watch. It's probably more interesting before I'm like 3 hours in and I like slowly feel myself going crazy. She's not depressed or she doesn't have cognitive issues. Oh, you know what I think it is? I think it's this. All right, let me just check. So hematocrit's fine, MCV's fine, platelets are fine, leukocytes fine. This is fine. Kind of elevated. Fine. So I don't, thyroid replacement therapy is not going to do anything. That's a trap answer. I don't think neuropsychological testing is needed because her MMSE is still good. I think it's hearing evaluation. I think it's actually hearing evaluation. I think it's hearing evaluation because of the fucking question stem. Oh my god. She doesn't attend movie nights. She doesn't attend bingo games. She doesn't watch her favorite television shows. And she doesn't call her family or friends. I think this is hearing. I think this is hearing. It's the things that you need your ears for, right? She doesn't call her family or friends, but she all of this is still fine, right? She's alert, attentive, pleasant, well-dressed, well-groomed. She's chilling. She's not depressed. She hasn't fallen. She's 27 out of 30 on her MMSE. Like, your BMI is fine. Like, dude, this is crazy. This is like a House MD moment. Holy shit, 7.5 TSH. Yes, her TSH is elevated, but not to the point where it's actually symptomatic or where her T4 is too high. Rule of thumb, really, if I'm going through TSH and I'm not trying to look for hypothyroidism, 10? TSH of 10, honestly, I'm okay with. Like, I don't treat anything like that. Unless the patient is symptomatic, but obviously the patient's not symptomatic here. Dude, it's hearing about... Oh my god! Yo, that was crazy! Look, you know, if this wasn't here, the answer 100% would have been mood, right? It would have been screen her for mood, right? Screen her for driving. Dude, where is the medicine? I thought I was gonna get to do medicine. Fuck you. Fuck you. The mood ring came back red. The doctor does not get to do his job. God damn it. That was crazy, though. I was like, why would it be hearing evaluation? And I was like, movie nights. Movie nights. Bingo games, favorite television shows, family and friends calling. Jesus. This is such a weird question. Exactly. This had nothing to do with medicine. This was literally just like test taking strategies. Left out the patient going, huh? Every 5 seconds during the assessment. Yeah, if this was real life, maybe I'd probably get that first too. Huh? 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 Oh, fuck. Okay. We got, okay. Okay. Last one. I think this is actually a medical question, guys. We can do this. Guys, we got this. All right. 23-year-old woman with known type 1 diabetes and systemic lupus is admitted with low-grade fever, nausea, and headache. Oh, guys, it's lupus. 23-year-old with all of the autoimmunes, right? So she has type 1 diabetes, lupus, and she's got fever, nausea, and headache. She takes prednisone, hydroxychloroquine. Nice. Hydroxychloroquine is first line in lupus. I talked about this in my Iron Mouse lupus lecture. More primary care providers should feel comfortable prescribing Plaquenil and then referring to rheumatology. Don't just snow out the patient with anti-inflammatories and then expect the rheumatologist to get any useful data out of that. Hydroxychloroquine is the first line medicine, but you also need to get your retinas checked because hydroxychloroquine is toxic to the eyes. All right, so prednisone, hydroxychloroquine, and multiple daily injections of insulin. She also uses decongestions for seasonal allergies and omeprazole for acid reflux. Initial lab results are as follows. So platelets high but fine, leukocytes fine, bicarb fine. So she's acidotic. So lumbar puncture shows a protein of 23 and no white blood cells. Wait, what? I thought we were doing DKA here. Okay, so SLE and type 1 diabetes. Let me guess, she's got Hashimoto's and celiacs and PBC. Oh, of course she has PBC. She's a woman. Do not quote me on that. Do not quote me on baseline eye exam. All right, fine. Yeah, actually, this one needs a baseline. All right, baseline eye exam for a hydroxychloroquine patient. Fine. Baseline mammogram for a 35-year-old woman. No. Chat, clip him. No. Urinalysis shows no evidence of infection. Patient is treated with IV fluids and insulin. So she does have DKA, but they did an LP. I don't know why they got an LP. On the second day of hospitalization, she complains of worsening headache and blurry vision. On physical exam, she's mildly lethargic. There's right-sided... What? Right-sided periorbital swelling and tenderness over the maxilla. So she has like a sinus infection. There's no lymph node enlargement and the neck is supple. Chest exam is unremarkable. Why did they do an LP? She has DKA. Why did they do an LP? What the heck? What's he playing? I'm just doing board questions. So at the end of all your training, at the end of med school, at the end of residency, when you get your license, you have to take the internal medicine boards to be, you know, like licensed as an internal medicine doctor. So that's why you take an exam. And then this is just like a practice resource for, you know, the actual exam. Anesthesia resident needs numbers, therefore they got an LP. Wait, is she febrile still? We don't have a temperature? Oh, no. Now she has like more of an infection. Patient would most likely require which of the following? Anti-pseudomonal antibiotics, MR angiography of the neck, repeat lung puncture, repeat lumbar puncture, surgical treatment, transesophageal echo. What the fuck? Okay, diabetes. All right, so anti-pseudomonal antibiotics is probably on there. They do LP for headache and look for neuropsych loop. Jesus Christ. Dr. Saiken, is it normal for your attending to give you the Darth Vader glare if you don't know all the blood mineral stats? Realistically, no. All right. If you're a June second year on the floor doing your service and you don't know every single BMP value, probably not. If you're a July intern and you did not write down every single number in the Chem 7 for one of like the 3 patients that you have, probably. Like, honestly, what you learn in residency is going to be the habits that you carry with you in your practice. And when I have July interns and I'm working with interns, I want to know that they know how to think, right? Like, I want them to name the numbers and I want them to tell me if they're normal or not. I don't want them to just say chest x-ray looked fine, vitals were fine, right? Like, tell me what fine means, right? Don't give me the radiologist interpretation. Don't just say that they were afebrile. Like, I want to know that you know what the temperature is, right? Because interns need to know that they're taking over the care of their patients, right? So they're taking over the care of a patient and they're responsible for all the numbers and the labs and the data is coming out of it. So I'm going to be a lot harder on a July intern than like a June second year, but that's just because I want them to understand like what they're doing and why. Can someone please say what he's playing? I'm playing internal medicine board review. I'm just doing practice questions. Ooh, mucormycosis in the face. Yeah, so she's diabetic. She's diabetic and she's immunosuppressed because she's got lupus. So she's on steroids and Plaquenil. That's a good one. So you would do like amphotericin, right? So surgical treatment in order to debride. Diabetes, prednisone, and lupus increase the risk of invasive mucor. Yeah. Ooh, I don't trust you to say something is fine yet. Yeah, that is a good one. Yeah, right, because it's like, I know you graduated med school. I know you know what a fever is, but I need you to understand that you need to report these things to me because I can't just take you for your word when you say things are normal, right? Like, oh yeah, patient's blood sugar was fine. Like, what is fine, right? You can read out all these labs and just say that these are all fine, but then be like, oh wait, the bicarb is 18. Like, actually, wait, they might be acidotic. Oh, we're still treating them with insulin. Oh, she's still in DKA, blah, blah, blah. So I think it's surgical debridement, yeah. This, actually, honestly, that was clutch. I had no idea what the fuck they were talking about. Can the patient drive? I don't know. Can we do a mood check? So right-sided periorbital swelling and tenderness over the maxilla is this big-ass ball of mucor. Ooh, mucor mic. Is this the one that's like black, right? I remember the sketchy for this. It's like an oil change station because it's like mucor is like a black fungus or something. That looks crazy. Ugh. ID now. Surgical and ampho. Jeez, gross. I still don't know why they did an LP. Why did they do an LP? Oh wait, this is only 29 questions. Wait, I've only done 29 questions. Should I do 30? Fuck. I am the winner! Surgical intervention combined with IV amphotericin B is needed to achieve cure. That's why you're the ID doctor, and I'm the hospital medicine doctor. They just felt like breaking out the big needle. Can you pause the stream so I don't miss out on anything? You can take screenshots. Copyright you globe. Copyright you globe. Do not attempt to copy, paste, or screenshot anything that might show up here. Dude, I have an exact patient at the hospital right now. Oh, really? Wow. Oh my god, wait, Conan Liu is in my chat. Hi, Conan. Hi. I watched all your videos. Wait. Okay. So guys, this is Conan Liu. He previously known in a past life as Evil Genius's Suppy. He was an SE2 player for EG. This guy like saved my ass in residency. He's like in the UC system, but he made these awesome residency guides. I know there are a bunch of med students and residents in the chat right now, and he made a bunch of residency guides that saved my ass in the ICU, on the wards. He has a bunch of videos on stuff like Dr. Dole and just going through like board review and stuff. So the fact that like I'm doing board review right now, even though I don't need to, is like what he does. Like he just does board questions for fun. Like Conan actually still does Anki videos for fun. Like this dude like makes Anki cards like as like a third year attending right now. And that's just like so awesome. Like, I've been watching your vids a bunch this past week. No fucking way! What? Oh my god, Conan Liu knows who I am! What the hell? Oh my god, what the heck? Okay. Yeah, also Conan is part of like the YouTube health partner program that I'm trying to get. So that's actually where I discovered it from, because he still has like a bunch of old videos. Like he's got like Valorant lineup videos and like car reviews and stuff. And on those videos, they have the banner that says like from a doctor licensed to the United States. And I just think that's like the funniest thing ever. So I feel like as a VTuber, I want to get that too. So then I could just have like a random like a cover or something, and it says like from a doctor licensed in the United States. Car reviews, yeah, no. So I mean, Conan's channel is been around a lot longer than mine. He has like old vlogs from like I think his like UC days. He's got like vlogs from like going to DreamHack as like a StarCraft player, a bunch of other stuff like Valorant, CS, and all this stuff. And then he went to med school, and he still made content during this time. He went to residency, he still made content during this time. He became an attending, and he still made content. So definitely like. If I had to like put like doctor YouTubers on a pedestal, like Conan Liu and Will Flannery, Dr. Glaucomflecken, top 2 for me, 100%. So like the fact that he's in my chat right now and I'm literally like, I'm like reciting, dude, I'm like reciting your resume right now. Like, I'm sorry if that's creepy. I just like you make such awesome guides. Like your ventilator one, I've watched like 10 times during my intern year, and it was awesome. You'll get the doctor branding pretty easily. Your content is dope. I'm trying. I was able to participate in their like boot camp thing with Lana Rhodes. And the biggest thing for them is they're just like questioning if they can give this to a VTuber. Because, you know, all of you guys, like you, Glaucomflecken, Prezro, whatever, like obviously you guys are showing your face, so you can tie your identity to, you know, the name on your license. Like obviously, like I sent in the screenshot of my license, I sent in my name and everything, but it's like, you know, do they see me as like my IRL identity representing my VTuber character? So that was something that they were like, oh, actually, let me follow up on that. But I never actually really got a clear answer from them. I passed like everything else. Like I got YouTube partner, I have all the watch hours, I have all the views and everything. But it's like, this is actually the first time they've ever had a VTuber apply for this program. So Lana was like, give me a second. I applied exactly 1 month ago. This was like May 22nd or something. So they do say give it 1 to 2 months. So I'm still within the window. But I'm just like, yeah, man, I just want this shit. Hope you get it. Thank you. Oh my god, guys, I can't believe Conan Liu is here. Anyway, hi. My name is Saiken. I'm currently I'm an internal medicine hospitalist. I'm also in an administration fellowship, so I do a bit of database science, admin work, and my program also pays for my MBA. So I'm actually a 0.5 FTE hospitalist, but yeah, I'm in an academic system, so I have residents who work under me, and I stole this undisclosed, undefined board review resource from one of the PGY3s that's taking boards next month. And I was like, hey, can I just have your, you know, your blank redacted login so I can just like do some board questions? And he was like, yeah, sure. So I was like, yeah, sure, I'll stream it. It'd definitely be lame if they didn't give it, just because you're a VTuber, you're still a real doctor making legit medical education content. Yeah, like it would be lame. I understand why they're hesitant about it, because I am the first one to do it like this. But yeah, it would just suck if they didn't. I hope that you get what I want, but say where I can find this website, please. It is an internal medicine board review resource. It is technically a paid resource, and they technically, you know, have like a screen sharing policy, which is why I'm not saying the name. Just become an internal medicine doctor, and then finish med school and pass residency and make it to boards, and then you too can buy this resource for yourself. Is this game on Steam? Right? All right, guys, should we answer one more for Conan? All right, I think it's just because it was like, okay, this is the 30th question. This is the 30th question. I got this. I can do 30 questions in 3.5 hours. You're good at making these board questions. Very fun to watch you do it. I actually recorded a vid reacting to one of your vids. I think I'm gonna edit and post it later today. What the hell? Oh my god. What? Oh my god, that is... Oh, I need to send this to my girlfriend right now. Like, oh my god. Oh my god. Conan knows who I am. Oh my god, wait, that is awesome. Wow, yes, please post that. I will retweet it and do everything I can. Holy shit. Wait, I'm fanboying so hard right now. Guys, I'm hot flashing. All right. Well, last question. Let's do it for Dr. Liu. Okay. Dude. Conan even has a video on like watching link click and making Anki cards to like learn Chinese through watching link click. I was like, what the fuck? It's so random. But he's just like me, for real. Wait, he has a girlfriend? Yeah, I know it's hard to believe. Unfortunately. As much as I LARP as a kissless virgin. I'm sorry. All right, yeah, guys, we gotta lock in. Come on, let's go. Okay. 52-year-old woman comes to the physician for a routine follow-up. She has no complaints and thinks of herself as pretty healthy. Oh, okay. That's always a good sign when the patient's like, pretty healthy. She takes lisinopril and hydrochlorothiazide for hypertension and lansoprazole for GERD. She was treated with isoniazid for latent TB 7 years ago. Okay, so this is definitely something that you always want to see. Is she still taking isoniazid or not? I guess not. So she is on 2 blood pressure drugs and a reflux medicine. Her mother died of uterine cancer at 62. She doesn't smoke. She jogs 3 miles a... Damn, 3 miles a day at 52? Wait, that's pretty good. What? I can't remember the last time I jogged for like more than a mile. I can't remember the last time I jogged. Who jogs 3 miles? Dude, 3 miles is like a 5K. I don't think I've done that since like freshman year of college. All right, she takes 2,000 units of vitamin D3 a day orally as a dietary supplement. I can't remember the last time I saw sunlight. Blood pressure is 139/82 and pulse is 74. BMI is 28. There's no neck masses or lymph node enlargement. The old school isoniazid monotherapy for TB. Breast exams are unremarkable. Okay, lungs are clear to auscultation. Spleen is not palpable. There's no skin rashes. So she doesn't even have complaints. She's here for a routine follow-up. What are we looking at? So sodium fine, potassium is fine, chloride's fine, creatinine's fine, calcium's high. Glucose, yeah, low, but it's fine. Albumin's fine. Repeat calcium is 12:1. Okay. Hydrochlorothiazide is discontinued. Which of the following is the most likely diagnosis? Okay, so do we have a vitamin D level? We don't have a 25 OH level either. Okay. Are we concerned about active granulomatous disease? If we had active granulomatous disease, we would have increased peripheral conversion of 25 to 125, and we would have an increased absorption of calcium. She was treated for 7 years ago. She has no complaints. She's jogging 3 miles a day. I don't know if she has like active TB. Occult malignancy. I mean, she could have an occult malignancy. She could be, busting through a bunch of cells. But if you were worried about cell breakdown and things, you would have potassium also high as well. So I'm not thinking like tumor lysis syndrome, get her to the hospital, get her some resburicase. Osteoporosis, she's 52. Right? She's 52. What are we doing here? I mean, she's 52. She has no complaints. She takes D3 orally as a supplement. Parathyroid adenoma. I mean, it's not impossible that she couldn't have a parathyroid adenoma. Wait, daily 2,000 is 14,000 weekly. I mean, what is the once weekly D dose? I feel like the vitamin D that I take is 1,000, right? Yeah, the once weekly D dose is 50,000, right? So it's not terrible. This is okay, damn. I hope Conan left because I actually don't know. There's a lot of things that could be wrong, but it's asking for like the most likely diagnosis. Plus sun exposure for 3 miles, right? Like it's not that high. If your once weekly D dose is 50,000, 14,000 is not that high. But you only do it for 6 to 8 weeks. She's probably doing this for a long time. Oh, true. So if she's having a vitamin D deficiency and then she has, what would you be concerned about? What? Like are you concerned about turnover? Or are we just concerned about hypercalcemia from the vitamin D toxicity? I think it's vitamin D toxicity because of fat accumulation. Vitamin A, vitamin D, vitamin E, and vitamin K are fat-soluble vitamins. So if you do take a bunch of them over time, you can get too much D in your system. So if we are concerned about vitamin D toxicity, what I'm worried about is the diagnosis part, right? So yes, I think she's overdosing on vitamin D, right? Because vitamin D toxicity, vitamin D supplementation, 2,000 a day for who knows how long she's been taking this. We are having too much vitamin D. If we have too much vitamin D, we need the gut to absorb more calcium, or it makes the gut absorb more calcium. And if the gut absorbs more calcium, then what does your parathyroid do to respond to that, right? Am I overthinking this? So you get too much calcium, and then from there, we are basically what I'm trying to say is this osteoporosis or vitamin D toxicity? Like I know what's going on, I just don't know what the answer is. Like the hypercalcemia, what directly is leading to the hypercalcemia? Is it vitamin D toxicity because the gut is forced to absorb more calcium? Or is it osteoporosis because now it's a bone resorption problem and her body... Yeah, if they gave PTH, it would be more helpful. Like, is it vitamin D toxicity or is it osteoporosis? Is this an absorption from too much vitamin D, or is this a bone resorption problem from the body telling the bones to give up their calcium? All right, fuck it. Vitamin D. Parathyroid adenoma! No! Do it! Just do it! Alright, well, this was clearly very rough because it was like a 48%er question too. Like, what the fuck? 37% said parathyroid adenoma. So, I mean, I feel like vitamin D toxicity was a very valid answer. Alright, let's go through this because I had a lot of trouble with this. Alright, primary hyperparathyroidism is the most common cause of hypercalcemia. Really? Okay, yeah. Primary hyperparathyroidism is the most common cause of hypercalcemia? Really? Not like, I don't know, dehydration? All right, whatever. Patients with primary hyperparathyroidism are usually asymptomatic and present with incidental hypercalcemia on routine laboratory testing. However, the serum calcium in primary hyperparathyroidism is only mildly elevated. So normally your parathyroids are these glands that sit behind your thyroid, and they secrete something called parathyroid hormone. And the way that this axis works is that it's there to balance out, you know, the levels of the phosphorus and calcium in your blood. The way I remember it from med school is like PTH is phosphorus trashing hormone. So it encourages the kidneys to excrete phosphorus, and it does that by pulling more calcium. And with PTH, you can leach calcium from the bones, because with high PTH, like from a tumor or something, independently producing PTH, it'll be like, I need calcium, I need calcium, I need calcium, and it'll start grabbing that from your bones. Number 1 is primary hyperparathyroid, number 2 is malignancy, number 3 is milk alkali. Yeah, I would have thought malignancy would have been higher because that covers all malignancies, and then primary hyperparathyroid is only one malignancy. Milk alkali being 3 is that's crazy too. That's like the one if you take too much like aluminum, like Maalox or whatever. All right, so hydrochlorothiazide can also slightly increase calcium to a serum. Okay, but that's fine because we discontinued the HCTZ. This patient is asymptomatic and was incidentally found to have mild hypercalcemia. The most likely etiology of her hypercalcemia is primary hyperparathyroidism, which is the most often caused by a parathyroid adenoma. So, I mean, if primary hyperthyroidism is the most common cause of hypercalcemia, and she has hypercalcemia, then I guess it wants you to say that it's parathyroid. In my country, malignant hypercalcemia is more likely. Ooh. Yeah, but we're Americans, and they always ask us which is the most common, you know, American cancer, whatever. So is it vitamin D, more calcium, PTH up, osteoporosis? That's honestly what I was thinking, but I guess it's not. Like, I wasn't like completely sure if it was really going for the osteoporosis angle, because it's the opposite direction. If your PTH is up, if you had more calcium, then your PTH would actually go down if you didn't have an adenoma. If you had more vitamin D, you would absorb more calcium. If you didn't have an adenoma and it was just normal axis stuff, your PTH would go down because it would be like, oh, we've got tons of calcium, I don't need to steal any from the bones. So when it was like, oh, like, how would I get to osteoporosis from that? Well, then it doesn't make sense to get it from vitamin D, because if she had excess vitamin D causing increased calcium intake, and then you had increased calcium intake leading to low parathyroid, right? That doesn't necessarily line up with osteoporosis. But then I was like, what the heck? Like, how do you get osteoporosis from this? So that's why I was overthinking it. Your overthinking was so valid. So we ended up saying vitamin D toxicity because we were like, she's taken a ton of vitamin D, but we don't know why and for how long. So even though the weekly is 50,000 units, 2,000 units daily over time adds up, because 50,000 units, you only take like six. Yeah, I think my girlfriend had to take vitamin D. So there's only like 6 or 7 pills, 6, 7. And then you end up just rechecking the vitamin D level, and then you end up putting them on a daily supplement. 2,000 units of vitamin D3 daily. I mean, I was saying like I take 1,000. Like I don't think 2,000 daily plus jogging 3 miles a day really is going to put you at risk for toxicity. Patient is taking 2,000 units of D3 daily as a supplement, which is unlikely to cause toxicity. Most guidelines state that the tolerable upper limit of daily D3 intake is 4,000 units. Oh, okay, whatever. It is what it is. 2,000 is recommended for women at 60 plus, right? Because they are at risk for osteoporosis. So, man, my mom had to once take prescription strength vitamin D. Yeah, I mean most people, like, if it's below like 21, like you want to, or if it's below 10, you want to get on it early, right? I probably prescribed more vitamin D for younger patients in clinic during residency more than any other medication, like more than any other antidepressant, more than anything else. It was going for the vitamin D supplements because people don't go outside. Thinking about 2,000 daily is not that high. 2,000 daily, which is like 14,000 weekly, which, you know, how many weeks are you taking that over, right? So it's like, whatever, right? After 3 weeks, you would be taking more than normal. So if you take 50,000 a week for 6 weeks, then you're at 300,000. So like after like 15, 16 weeks, which they didn't give us a timeline on, I mean, she could be taking more than a weekly 50,000 supplements. What's outside? I don't know. Saya spreads serotonin into your stream. Thanks for the raid, guys. We're kind of checking out here. We were doing board review, and then we got blasted by a question that only 37% of people got correctly. So, dude, we were overthinking city. Let me copy your homework. I don't think you want to copy this. Oh man. All right,
Let me
I've been
copy
live
your
for like
homework.
3 hours 42 minutes. That was pretty good. I feel like, okay, so last time I did boards with JF and we went for like 4 hours, no problem. But I feel like 3 hours for me is where my sanity like goes. Like, how the hell did I do this like 10 hours a day last year? Like when for like step 1, or at least for me for boards, like, or step 2 even, I think, like you get like a break from school, or for like your rotations you get like maybe a month or two, and it's just, we just call that like dedicated, and it's just, you just wake up and you just do questions, you watch videos, you read your lectures over again, you just learn everything. Like I kind of miss having a dedicated study period, not gonna lie. Like it's like a very toxic routine because you're literally just like punishing yourself every day. But I mean, it's just so convenient, right? Like doing boards while like also doing my fellowship at the same time, like that was ass. And now it's like, oh my god, I can barely do 3 hours of this shit right now. What was your least favorite area of IM during residency? I was always weak in pulmonary, but many of our students like lungs way too much. Inpatient hemonc. Oh my god. Like there's just so much stuff. There's so many like guidelines. There's so many like new therapies. There's new chemo regimens that come out. So many private oncology groups that want to admit their patients for monitoring. So you need to familiarize yourself with their like 75 different protocols, like the most cutting edge, you know, like chemo trial with like one journal article and like 50,000 pages of private research done at like MD Anderson or Sloan Kettering or whatever. And these guys are like, hey, can you watch our patient, make sure they don't die overnight? I'm like, I don't know. Dedicated for step 2 right now, not too bad to be honest. Honestly, I will say I will never be as like smart medically, like in terms of like book knowledge, as I ever was before step 2. I think step 2 is just like the most specific exam, especially more so now that it's like the only one that's like graded compared to step 1, which is pass fail. Like step 2 is the most specific exam in terms of like book knowledge and like basic like rotation, like neuro, OB-GYN, surgery, family medicine, like those kinds of things. Like I will never know as much about those subjects as I ever did during step 2. Like I felt so smart during step 2, right? Which I did pretty average on, but like I just felt like, damn, I will never hold on to this amount of random specific knowledge from all these different fields ever again, right? Like step 1, like everybody forgets step 1 stuff, right? Like I don't remember which one is the oxidase positive, catalase positive, coagulase negative. I just remember the little plumber with the staph epidermidis, right? Like which viruses are positive sense versus negative sense, which is enveloped, which is not. Like that stuff is so useless for clinical practice. But like step 2, like dang, like I felt intelligent. I felt very intelligent. I loved heme onc. I got to do so many hematopoietic precursor transplants. I feel like had I known that I would have more of a hemonc job currently, because like some of the shifts that I pick up, we also have like a hemonc service, which also has like a rounding hemonc hospitalist, and it's like straight up like it's just 20 patients and they're all cancer and they're all on like inpatient chemo, and it's very difficult. Like I wish I had familiarized myself with that stuff more, like inpatient chemo. But we never actually like had inpatient chemo at the hospital where I trained at. It was mostly just like post chemo monitoring. So taking care of the emergencies sucked because we had to go through like this whole manual every single time like we got a new patient. But now, like as a hospitalist who potentially could be on that hemonc service, like I don't know what my job is, right? Like, do I ever make a call that would be different from the oncologist? Like, what do they want? And there's a solid service and there's a liquid service. Like, I don't know what the difference would be in managing those things. Anyway, that's why I didn't become an oncologist. Baltimore classification makes me go WTF sometimes. Like, how is this virus real? Oh my God. Do I want to look at one question to make me feel better? Okay, we can't end on a loss, guys. We can't end on a loss. Look, this is cardiac. It should be easy. Coronary angiogram shows 70% stenosis in the distal LAD. Actually, wait, he has 3rd degree AV block. Oh no, guys, I just clicked the question and I started highlighting things. I need help. I need an intervention. I need to go to bed. when you were with JF, it was 10 out of 10. You were on a roll. What did I get just now? I think I got maybe like 27 out of 30, 26 out of 30, 27 out of 30. Honestly, that's still pretty good. Dude, a 90% on boards? That's crazy. Your gamer is showing. Have you ever tried to quit? Do you open UWorld questions when you wake up in the morning? No, I'm just addicted to winning. I can't end on a loss. I gotta climb. All right. What's your mood? You need sleep. All right, we're gonna do this one. I'm gonna sign off. I'm gonna walk my dog. I'm gonna go to bed. You only missed a couple. I think it was 27. I'm gonna say it was 27 out of 30. All right. 72-year-old man comes to the office due to occasional lightheadedness over the last 3 months. It occurs both during exertion and at rest and lasts about 2 minutes. He's got no chest pain, dyspnea, syncope. Okay. Other medical issues: hypertension, hyperlipidemia, right hemicolectomy 8 years ago for colon cancer. Medications include low-dose aspirin, HCTZ, lisinopril, rosuvastatin. So he's on the right stuff for CAD for now. He's just missing a beta blocker, but he is having lightheadedness. Quit smoking 20 years ago. Good job. Drinks 2 or 3 beers on weekends. Totally fine. No regular exercise program. Same. 27 out of 30 is insane. Well, I mean, I took this exam like a year ago, so less than a year ago, like 11 months ago. So it's not like I'm superhuman. Physical exams unremarkable. Treadmill exercise stress test is performed. Exercises for 7 minutes and 20 seconds and achieves a workload of 7.0 mets at 90%. I mean, so he's good. No symptoms except fatigue. ECG shows no ST segment changes, suggested myocardial ischemia. But he randomly goes into 3rd degree AV black. Like, okay, well, so when you get to 3rd degree AV block, which is complete dissociation between the SA node and your ventricular rhythm, I don't think it matters if you have 70% stenosis in your distal LAD, and I don't think it matters that you're having any of this, because I'm pretty sure you're just randomly going into AV block. I would not bother Holter monitoring him. I would not just want to see him again. I would just go and put the pacemaker in right away. Because I think, like, most appropriate next step in management, you don't know, right? Like, you could send this guy home and then he goes into 3rd degree AV block and then he arrests. Like, he could just go into PEA like out of nowhere. So I feel pretty good about this one. Tilt table testing is violent. I don't think tilt table testing is ever the answer anymore, because I think they're really trying to move away from doing tilt table testing because of how just unpleasant it is, especially when you're diagnosing things like POTS. Like I said, I don't want to do the monitor or follow up with him. I think this is kind of a red herring. Coronary angiogram shows 70% stenosis in the distal LAD. Like, yes, it could be, but we literally put him to 7 meds, 90% maximal age predicted heart rate. He's doing fine. He's asymptomatic. Like, I will want to address that, but the 3rd degree AV block is literally going, address me. So I feel like that's the right answer. All right. 57% of people said this one. 35% still said that, but I mean, yeah, the patient is at high risk for recurrent complete AV block. So that's what I was saying, right? Like, you could technically send this guy home and he could drop dead. And I'm just like, that's not, we're not doing that. So let's put in the pacemaker. Okay, I redeemed myself. Dr. Liu was still here, so we're good. Yeah, we're chilling. It's yelling at you to pay attention to. Address me. That escalated real fast in the second half. No, it's like all those questions that are just like, oh, blah, 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 blah. Which of the following is the most common cancers in America? Like, that's why I like my general test taking strategy. Like, if I wasn't doing this from a narrative standpoint, is you always read the question first. You go through the answers, try to determine what they're asking, and then you go back and you go through the question knowing that they're trying to point you in a certain direction. But yeah. Whew. Okay, I did 31 board review questions. I don't think I have done that many questions since last year, like in one sitting ever. Jesus. Okay. I think I said this at the beginning of the stream, so I'm working this week, but I'm free on the weekend. I'm gonna get brunch with my friend on Saturday, but either Saturday or Sunday, let's do the House MD visual novel for the Nintendo DS. I'm tired of border view. I know it gets views. I know it helped Conan Liu discover me, but I just want to play something stupid and still tangentially medically related that I can put on my channel. So we'll try to get that. Plug the Discord. I plug the Discord and I plug the Discord and then the Discord blocks everybody because it thinks I'm getting hate rated. I love that you thought 40 was out of the question, but you got pretty close. I need you to text me whenever you play that House MD game. Yeah, okay, it'll be Saturday or Sunday. I will figure out when it is after I get off service. Will you be playing the new Persona on stream? I mean, dude, that's gonna be like 7 years away or something. Like, I remember my freshman year of college, that one Persona 5 trailer, like, you are a slave, want emancipation? That one? That came out my freshman year. P5 came out my senior year, right? Like, I mean, I do want to play it. Just will you hold me to this 3-4 years later? Play Toho someday? I played Scarlet Weather Rhapsody. Does that count? I'm a faker. All right, guys. There's a House MD visual novel game. Okay, I don't really know if it's a visual novel or not. I just know it is like a DS game. I'll look it up right now. Totally not a VN, an adventure game that focuses on mini games with brief story segments. Oh, okay. I'm sorry. I'm a faker. I'm a liar. I'm a lie guy. Atlas bans people from playing Persona. It happened for 5. Isn't it just like you can't stream the game after a certain in-game date? Because I remember that's what happened like for that's what happened for P5. Like you couldn't stream past October or something, but whatever. Play Opry. I'm not a surgeon. Gross. All right, everybody. I hope you have a good rest of the week. If you're working, I hope you have a good weekend. Potentially, I'll see you guys on said weekend. Take care of yourselves. Drink water. Take your meds as instructed. Have a good one. Stay healthy. Bye-bye.